Hello, everybody. I'm sorry for the delay, but apparently we're all ready to go now. We're all live. So thank you very much. Um, Good afternoon and welcome to the fourth. I don't know if this will be the final one yet. We might be having another one, but it's the fourth Health and Adult Social Care Review and Scrutiny Committee of this municipal year. Before we start these proceedings, may I bring to your attention to some housekeeping matters. We have to do this every meeting, so there is no expected fire alarm testing today. Therefore, if the fire alarm sounds, please follow the fire and emergency procedures that are applicable to the council house. This meeting will be broadcast live to the internet and will be capable of subsequent repeated viewing by entering the Warspite room. Committee members are consenting to being filmed throughout the meeting and to the use of those recordings for webcasting. Please can I ask that you speak clearly and directly into your microphone when addressing the meeting so that online participants and the public can hear, and that it is switched off when you're not using it. Your mobile devices are turned to silent. So, item 1 on the agenda, apologies. Elliot?
Thank you, Chair. Apologies received from Councillor Toohey. Councillor Rainsford is substituting today, and apologies received from Councillors Finn and Watkin. Thank you.
So we've had nothing from Stefan?
Not today, Chair.
Okay, thank you. Declarations of interest. Any declarations of interest from committee members?
I work at Downwood Hospital, University Hospitals Trust.
Thank you. Anybody else? Again, we approved the minutes of the last meeting held on 30th of December as a correct record. We got, everybody agree? Yeah, we got a seconder. Natalie. Okay. Any abstentions? No. Okay. Item 4, Chair's urgent business. I have got one little bit. Councillor Aspinall, as you're aware, there's been an epidemic of measles right across, apparently in some areas of the country. Can you just give us a quick update of, have we got any worries in Plymouth?
Thank you very much, Chair, for that. Across England, there's been 465 cases confirmed of measles. There was a smaller number, this is from October to February, the smaller number in October and November, but it jumped up to 161, again, across the country, and 240 in January. So most of these have been, a high proportion of these have been in the West Midlands and London, although there's been a few outbreaks in Yorkshire and Humber. So the majority of these children are children under the age of 10. We've had 7 cases confirmed in the southwest, and what's basically going to be happening now is, as most of us that are parents know, it's a 2-jab thing, measles, mumps and rubella vaccine, and so they're going to be looking at not as sort of 1 to 5-year-olds to check with their GP practices they've had their 2 jabs. And again, there'll be a recall for 6 to 11-year-olds to make sure that they've had theirs. And in fact, if anybody's between 17 and 30 and you haven't had your jabs, you can go and get them. Your GPs will be doing that to support the effort. But I think the main thing is, if you hear of anybody wanting advice, this is a really good jab and it does prevent a lot of problems. No doubt John Mahoney will answer you any questions of the serious complications that can arise with measles, mumps or rubella. So whilst it's not a huge problem here in the southwest, we need to be cautious and to make sure that if any parents ask our advice, they should be doing what's good for them and their children. Thank you, Chair.
Thank you, Mary. So we're just going to go on to item 5, which is end of life care today. For some members today, it might be get close to their heart, and I'm not going to lie, it is to me, for obvious reasons. So we've got two parts. We've got a part one and we've got a part two. So maybe after part one we'll have maybe like a little break or something, and then so people can go and have a toilet break or whatever they need to do. Mary, before we ask Chris and his team to present this, is there anything that you would like to say on this?
Chair, I think if we look at the inevitability of passing, we need to be making sure that we are doing the best for our citizens in Plymouth. And to me, that's an important part of life's journey. As many of you know, I'm certainly going to be looking at ageing well or full of life, whatever we end up calling the thing. And this is that part of that journey. So we need to make sure that anybody passing in Plymouth does it with dignity, in the place that they choose to be, and that they have adequate support. So that's what I'm really, really looking forward to finding out from this committee, what their input into that, so that the team can make sure that we are following what is expected and what we would want for our own. And that's the thing, isn't it? It's something that will affect us all personally. And as you say, it may be quite a difficult session, this. So please, if anybody feels they need to leave the room for just to gather breath for a few minutes, nobody's going to feel anything worse about them than it's essential that we all feel comfortable, that we can speak as we find. So I say looking forward, and I don't mean that sounds a bit off, but I think what comes out of today will be one of those pillars that we need to be looking at, because it isn't just living well, it's making sure that our passing is good as well. So thank you, Chair, for this opportunity to be here.
Thank you, Mary. So what I'm going to do is I'm going to pass over now to Chris, Jane, is that Shane, sorry, Jonathan, Tricia and Sharon. And for you're going to just present this to us today, and hopefully what we get out of this is some positive from us, positive feedback to you. But what I'm hoping is that actually it's not all pink and fluffy, and we do understand that that you have got issues. There is issues with end of life, and for us as a committee to have that, I'd rather you gave it to all of us the truth rather than trying to hide anything, because that's what we're here for. Okay, thank you.
Thank you, Chair. So yeah, we've got quite a deck of slides that we're going to take you through today, and obviously colleagues will come in, and as you say there, we want to be very open in terms of some of the challenges that we have around service provision currently. Do you want to go on to the next slide? Thank you. So we'll talk a bit about some of the responsibilities from NHS Dev and the ICB has, some of the work that's already underway around improvement activity, some of the frameworks that describe best practice, and also some of the data that we've got. We'll talk through that and point to those areas where we know that there's some improvements that we need to make. Understanding, and as has been described, this is a very emotive subject, and actually when things don't go right, the impact that it has on individuals, families, staff who are supporting individuals too, is really significant. So we're totally committed in terms of the improvements that need to be made here. You'll see we'll then pass on to the different partners who are involved in delivering services from a health perspective around end-of-life care. So colleagues in University Hospitals Plymouth, Live Well and St Luke's are here today, and they'll talk about their component parts of the service offer at end of life. And then we'll talk a bit in part two around some of the development work that's already underway, and some of the pilots and areas of improvement that we're already focused on, to give you a bit of an update and some detail around that. But we'll obviously stop at various points for questions and things in order to allow for that. So this first slide just pulls together a quick summary in terms of the responsibilities from a ICB perspective. So under statute, integrated care systems have a really key role in delivering and in ensuring that we've got palliative and end-of-life care services that are able to meet the needs of individuals. And there's a duty on ICB specifically to commission those services within the ICS footprint. and that's set out within statutory guidance. There's been an amendment that includes palliative care services where it talks about the ICB's legal responsibilities to make sure that we're meeting the population needs, and that's from an ICB perspective delivered across Devon, with an expectation that we have a clear vision of how we have care and support packages of services and how we commission on a local level in order to meet what's set out in the ambitions framework. So that's sets out the best practice standards and the areas that we should have for a good working end of life service for individuals. We'll talk a bit more in detail around some of that later on in the slides. I think it's also worth recognising, there are a number of partners here with us today, but end of life care requires a real proactive system approach, so strong working between partners. We'll talk quite a lot today about the health aspects of that, but dying is a social journey too. So I think it is a risk that we can become quite medicalised in it. And whilst we need to describe that today in terms of our roles there, really keen that we also talk about actually what as a community we can do to raise awareness and support people. We'll talk a bit more around that in terms of what some of the thoughts around from a Plymouth perspective, and again keen to pick up further discussions around that. There's also a need for us to make sure that we've got sufficient workforce. So we know that all parts of our system are challenged in terms of workforce and capacity, but absolutely need to make sure that our strategy and our approach to configuring services to support people at end of life is cognizant to that. We have plans that help us in terms of having the right workforce in the right place, and having those multidisciplinary team approaches that can support people in a flexible way in order to meet the needs that those individuals have. So in terms of some of the governance and oversight arrangements that we have at Devon and then at Plymouth level, so within Devon there's a well-established multi-organisation, multidisciplinary end-of-life steering group. So that brings together health partners, social care, local authorities, voluntary community sector together to oversee, monitor and make recommendations to NHS Devon on the delivery of end-of-life services across Devon, and how we can make improvements where there might be inequity in terms of provision across the patch, and focus some of our activity around there. What that then feeds down to, obviously makes those recommendations to the ICB, who then have that responsibility for ensuring that we're meeting national, local and best practice guidance. And then locally within Plymouth, we've got a locality steering group, which again brings together all of those different partners, and very much looks at, from a Plymouth perspective, how do we translate some of that's coming down from a Devon-wide perspective in order to improve services within Plymouth. So this next slide just sets out a little bit in terms of some of the definitions around end of life, and recognising that there's a continuum and a journey in terms of the different points and different types of support that at different stages in people's end of life care. So you can see the biggest circle there in terms of palliative care. So actually that's where we talk about early symptom management, some of those advanced care planning, early after diagnosis in order to support an individual. Then that lighter blue circle, end of life care, so that tends to be around where there's weeks and months of life left and the individuals are receiving active palliative or medical treatment, ongoing support, input from a hospice, and it's more around kind of respite and caregiver relief at that stage. And that last circle there, you can see where we're talking about the very final stage in terms of those last days and hours of care. I think it's worth recognising that for different individuals, the types of support will differ at different times. So you'll see in terms of the best practice guidance and some of the things that we're looking to do, how we wrap around to coordinate care for those individuals, but do that in a very personalised and flexible way in order to recognise and respond to some of that. This next slide, so there's a couple of things just to pull out from in here. So this picks out from the gold standards framework and it looks at average GP workload. This is national data, but you can see there in terms of the proportions of sudden or unexpected deaths, it's a very, very small proportion compared to some of those other types of cancer, frailty, organ failure, things like that in terms of reasons for death, which are obviously more predictable. And again, then you can see in terms of the graphs on the side there, it shows the deterioration of individuals at different stages. And obviously what we want to do.
Sorry, Chris. Couple of members are having difficulty hearing what you're
Oh,
saying.
sorry, I'll pull this a bit closer.
Is it possible if we just carry on and then we'll see if that's any better for the members that are finding it difficult to hear what you're saying? Is that all right?
Sure, apologies. Is
That's
that hopefully helps me better? Okay. So then this next slide, this just pulls together some of the gives it a bit of an insight in terms of from population statistics for Plymouth. So this was from the latest census data in 2021, and you can see there for the population of Plymouth, the expected death rate 2,647, and then the proportions again, as I was saying earlier, a small proportion of that, only 5%, is sudden death, and the others are, you can see kind of the key reasons behind that. Worth acknowledging, that's the Plymouth position, but obviously for University Hospitals Plymouth, it covers that wider population into Eastern Cornwall and Western Devon, and for that period it was 4,200 deaths, so that just gives a little bit of a understanding around some of the numbers there. This slide deck, so this provides Devon-wide data. This isn't specifically Plymouth here, but the two areas that we've circled in red really are the bits of the dashboard that we've got around end of life that I think are most pertinent to talk about today, and wanted to bring to your attention. So the first one there, the place of death, as you can see it on a Devon level, the greatest proportion of people are dying in hospital. I'll talk a bit more about the Plymouth component of that because we've got a Plymouth split of that at the moment. And then the other circle describes causes of death. So we can see again the biggest percentage of that is frailty, but obviously cancer and organ failure behind that, as per the last slide. So this next slide looks at that place of death data and compares broader Devon with the Plymouth position. And what's really stark here is the greater percentage of people who are dying in hospital in Plymouth compared to the rest of Devon. And you can see actually the care home position is pretty similar. What we see is far fewer people dying at home. And that is an area of focus that we need to have. And you'll hear around some of the work that's been undertaken in order to address that. But that's an area that we really need to focus on within the city. How do we support more people where their preferred place of death is home to have that, and how we wrap the support around them rather than them passing away in hospital.
Chris, can I just ask, you've given this this slide here, and we've got like 25%, 29%, 4%, but we actually haven't got any figures. I mean, those percentages don't really mean nothing without figures, if I'm being totally honest.
Sure. In terms of the numbers of individuals, okay, we can get that data.
I
we
mean,
can share that.
you know, 27% could be 20% of 200 people or 10 people. So we do need figures on top of that as well. And I'm, you know, that would be really, really helpful.
Yeah. So part of the challenge, and we'll pick this up a little bit, in terms of some of the data that we've got around end of life is quite limited and difficult to split it by Plymouth, but we'll be able to get that in terms of the actual numbers. Yeah.
Will, have you got a question?
Just on the place of sorry. We've got the place of death Devon area, place of death UHP data. So is that Plymouth City Council boundary or the area, the hospital? Because there is a map further on, isn't there? And it's Cornwall, West Devon, South Hams part that.
Yeah. So you're right. Well, that's the it's the University Hospitals Plymouth, so the Derriford Hospital, so that is the 4,200 deaths for the 2021 year in terms of the census data. So I can't do the percentages off the top of my head, but the 100% is 4,200, if that gives you an idea.
John, did you want to ask? No.
We did have the figures split down for UHP and for the Plymouth area, didn't we?
Yep.
2,647 expected.
Patrick?
Yeah, thank you, Chair. Are we going to take some questions as we go along, or? I don't know.
I think we probably should, because it's quite a lot of data, and I
Yeah.
think if we leave it till the end, then it might be. Are you all right with that, Chris?
Yeah, that's
Because I
absolutely
think
right. Yeah, if it helps
I think
clarify things, I'm happy to do that.
we'll just go on, and then it will
Sure.
be quite a lot at the end. So yeah, I'm quite happy for questions to be asked along the way.
Thanks, Pauline. So just one quick one on the slide that basically a place of death and the comparison with Devon. So on the UHP 48% in hospital, so is there any immediate sort of statement that would justify why that's far greater than wider Devon at this point, Chris, even though more work's going to be taking place? Thank you.
Thank you. So we'll come on to that, I think, when we get to the UHP slides. Rachel, I don't know if there's anything you'd want to say.
Yeah, I think it
Yeah,
talks about
thanks.
the wider spectrum of services that we have available, but also it's worth I think probably to help committee members that we benchmark this with other tertiary providers because of the nature of UHP and its footprint into East Cornwall, but also the wider footprints. That might also be helpful as additional information to help benchmark that as a comparison. But certainly, you know, I think a theme throughout all of this presentation is, as far as possible, wanting to meet people's wishes. And where we are able to support that at home, that's absolutely the priority of the work that we're going to be describing today, and how we can support that with our partners across the range of provision.
Thank you. Can I just ask one question back to Chris in terms of sort of the global Devon situation? So obviously hospitals are generally about keeping people alive. So is there, in the course of this discussion this afternoon, any further sort of guidance as to when a hospital setting accepts that somebody goes from trying to be saved and life extended to moving into, unfortunately, an end of life situation? Are we addressing that further in the discussion this afternoon?
I can answer just a little bit of that. There will be some detail that we'll come on to, and I think that's one of our challenges, is around at what point somebody becomes not for active treatment and for supportive care, and I think that's one of the challenges. So I'll talk about that in terms of some of our project work, but that is one of our questions of the day, really, is just that.
Thank you, Chair.
Person.
Thank you, Chair. Two questions. The first one relates specifically to this slide. You've got two different hospital figures, one for Plymouth, one for Devon. The hospital figures for Devon, I'm assuming Derriford has been taken out of that figure, has it? So there's does that mean there's some sort of read across between the two?
So it's the whole Devon footprint, so it will include Derriford. I think, I suppose this picks at the point around what this helps. So it isn't exact, is it, in terms of the data piece, but what this shows is, and as Rachel said, you know, there is other factors at play here, but it does just highlight the fact that more people are dying in hospital, and therefore our area of focus needs to be about how we support and prevent that.
Okay. The second question, it may be something you're going to cover later on, but the percentage of patients who are dying in hospital is obviously high, as we can see. Has any assessment, are you able to make any assessment of how many of those people wanted to be in a hospice and not able to go, or had all those people been offered a hospice place but have somehow ended up in hospital and have no choice?
So that's more difficult in terms of the data that we've got at the minute. We will talk a little bit around some of the vital signs work and some of the other things that we want to start doing to capture some of that data so that we can measure performance against that. I think it is, you know, and it is fair to say we haven't been able to support that option for all people. We haven't had the provision. We've started to see some improvements, and some of the work that we'll talk through and partners will talk through later will start to describe some of the actions that are being undertaken around that.
Steve?
Just a point of clarification. Where it says cause of death frailty, is that just old age? Is that what we mean? They're just 100 years old and they've died naturally?
So it's more, I mean, it will describe a range of things, but it's individuals who will have a level of frailty, could be associated, well, we will be associated with old age. What we do know within Plymouth is we've got very high levels of frailty, particularly at a lower age point, and there's links to that in terms of deprivation and some of the factors that we see within a city. So for Plymouth, that we would expect to see a higher proportion around that, but that absolutely focuses some of our other work in terms of how we support those individuals.
Chris, is it mainly just people that are very old and have died naturally?
Predominantly, yeah.
Okay, Chris, you want to carry on?
So this just points out a couple of bits in terms of some of the data. So we've talked about that already in terms of the proportion dying in hospital rather than at home. There has been some data that showed during 2023 a drop in terms of the number of people dying at home, but we still know that there's more to do. And the other thing that I'd also point to is some of the recognition and recording of people at end of life. So you can see there the percentages. We haven't got this from a Plymouth perspective, but it'd be broadly similar in terms of the Devon-wide position. So only 0.37% of people who die are on a palliative, 0.37% of a GP's registered population are on a end-of-life register, compared to Dorset's comparator of 0.82 and national best practice is 1%. So we've got a long way to go in terms of making sure that A, we're identifying people, and B, that we're recording them. But again, we'll talk about some of the work that's being undertaken there. Alison?
Alison, yeah.
Thank you, Chair. Just on that point of the recognition and recording of end of life, looking at the other bits of text we've got around that, it doesn't seem to be standardised across the different bodies. Is that the case? And if it is, shouldn't it be standardised?
So consistency and standardisation, yes, I'd agree, and that's one of the things we'll talk about in terms of how we coordinate that within Plymouth to make sure that we've got all partners doing that.
Paul?
Thanks, Chair. I see that the figure of 0.37 and the figure of 0.82, one looks very low, one looks very high. Are we very low and they very high? What about some other counties?
We're low, so 0.37% of best practice is 1%. So we're
That is a shockingly low figure, yeah. And what is the sort? I presume Dorset's quite high. What's the sort of average you'd be looking at around the country?
I don't think we've got that data, but we can check that and clarify that, Paul. That's helpful.
Sean?
Thank you, Chris. I mean, 1% of people might be within their last year of life, but not all the people will know that. And presumably not all people will even be ill, because people do die quite quickly and quite suddenly. One's got to be a bit careful here, I think, about putting people on end-of-life protocols before they need it. And I and others have probably heard of cases of people who've even gone on syringe drivers, which have then been taken down and they've lived for a considerable time afterwards. So, it's not always quite as clear cut how near the end of life people are, particularly when they just get very old and frail.
Thank you, John. I think that's a good point, and I guess it's more about recognising and identifying some of those individuals. We'll talk about the importance of having advanced care plan conversations as well later on. But you're absolutely right. For some individuals, that won't be appropriate or possible.
Just to add to that, I think that's where there's a real link around some of our frailty work and some of our long-term conditions work. So actually how you make sure there's good, active, across our pathway care plans that recognise, actually how people's needs are changing and actually what wraps around to support them. So we can support people to live as well as possible for longer and as independent as we can for longer. And that actually how we have the regularity, some of the work in the frailty MDTs that Liv will talk a little bit about, actually those regular contacts and support for people and their families that recognise that holistic need. So I think that's where that point around the broader nature of the conditions and the person, that we need to sit alongside our definition of end of life and palliative care just for that exact reason. Councillor.
Okay.
Thanks. So there's the next few slides have just got some data that's been pulled from the Plymouth Medical Examiner's Service. I'll just quickly take us through. So this first one looks at the number of deaths that take place in the emergency department at Derriford. So this is Plymouth data, and you can see there a spike towards the end of latter half of 2022 into 2023, but we have seen some improvements there since. But there is quite a lot of fluctuation and variation within that, and there is still further work that we need to do, but again we'll talk about that a bit later in terms of some of the work that's being progressed there. This next one looks at the comparison of the causes of death that take place either within the hospital or within the community, and you can see the greatest areas of variation there around areas such as respiratory more conditions, individuals with those conditions passing away in hospital rather than the community, frailty more in the community rather than hospital. Some of that you would expect in terms of the types of conditions that those individuals will have and the support, but what this helps to do is identify some of those areas where we might need to focus particular programmes of work in order to wrap around some of those individuals in that more proactive way in order to support their needs in order to reduce some of that variance.
What does VASC mean?
Vascular.
What would be an example of that?
Look to the clinician. So, yeah, blood clot.
Yeah,
Yeah.
something like that.
Blood clot, stroke.
Carry on, Chris.
Excellent. So this next slide, they've started through the Plymouth Medical Examiner team looking at gaining feedback from individuals' families who've been through bereavement, and the graphs that you've got on the side there show some of the variance from whether the feedback was positive or negative.
Alison, sorry.
Thank you, Chair. Sorry, a query again on the data and what the figure on the bottom line actually means. It's sort of numbered 1 to 12. Is that percentage? Is that a just bald number? And if it's a percentage, is it a percentage of what? Thank you.
Yeah, so it's months. The bottom on that one, sorry, is months. The 1 to 12. Yeah. So and then on the table on the right hand side, that's the number of instances instead. So the two line graphs, as I say, show the positive or negative, and you can see the variation there that we're seeing. Obviously, what we want to do is move to more positive and less negative. Clearly, that right hand bit picks out some of the themes. So you can see particularly there a higher proportion in terms of some of the themes around communication, provision of end-of-life care. So again, that helps us in understanding some of the clear service gaps that we've got and where we need to make sure that the provisions and the improvements that we're making focus around helping to address some of those issues.
Mary?
Might be cheeky and ask, Chris, who would have received that feedback? Is that something that's gone to PALS? Is it something that's gone to the wards? How has that feedback been put into place?
So there's a regular report that's reviewed through we have a daily huddle with each of our matrons where themes in terms of experiences are shared. From a governance perspective, we have our...
Sorry. Excuse me, Will and John, can I please ask you to listen to what somebody's trying to say? Other members here are trying to listen. Thank you.
No problem, that's okay. We also have our mortality review meeting that the Medical Examiner's Office feeds into to look at the themes. And as we talk a little later, there's been the themes from there that we've reviewed, which has led to the improvements that Shane and I are going to talk about. But I think we have to keep being cognizant of the fact that these themes, we've got to have an active plan for each of those, and I think that would be really welcome from committee members today. In what you hear is actually, are we describing as a collective team that those themes are being addressed?
Natalie?
So obviously you're saying about feedback. How are you getting that feedback, particularly if it's community based rather than in hospital? You know, how are you collecting that data?
So as part of the medical examiner's process, they will meet with families, they'll hear from families, and we have our complaints. So part of that is the work that's in that dialogue where those themes are collected, as well as the review of the experiences themselves. I think the Other thing I would say is that we, through the works of the Healthy Lives Partnership, that we come together with Live Well and through our locality group, looking at our wider comms and engagement work for end of life through that locality programme more broadly. So certainly there is more to do, not just in terms of when deaths happen, but also through the experience in that journey that Chris was describing.
Just add a supplement to that. So when somebody's formally put a complaint in, or are you just generally getting feedback?
They're offered and as part of the complaints process. It's broadly offered for those
As part of
individuals.
a complaints process rather than a general feedback.
So it's offered as part of the reviews of our deaths by the medical examination. There is an opportunity through our Meet Our Matron programme for individuals to speak to our matrons real time or afterwards as a follow-up to reach out for any feedback and to talk through any specifics.
Just in terms of the hospital's approach to feedback via this method, we, as part of our governance procedure, our end-of-life governance meeting procedure, we'll go through those line by line and look for themes. And I will personally meet people who have had a very difficult death, meeting carers. And I've met several families in the last few months around understanding and looking for improvements, and very often engaging those families in how some of those families have gone on to support other education events with the trust in order to be able to pass on, actually this is not what good looks like. So we're able to learn from that and pass on it's part of a catharsis as well for those families too. So but we have a structured process in terms of the hospital, how we manage that in terms of feedback from the ME office.
Okay, Chris.
Thanks. So then this last graph on here, so this comes back to the point we were describing earlier around knowing and identifying individuals. So the bottom line there shows those that were identified and on an end-of-life pathway, whereas the blue line is the total deaths that took place. So what we would want to see is some convergence. We're never going to get to an exact, the orange and blue lines being completely in line, but what we'd want to see through some of the improvements is how we bring that closer together. So just want to talk a little bit around some of the improvement work from a One Devon System NHS perspective that we're already undertaking. So, as we've described and outlined, we know that there is much more work that we need to do in order to improve the experience for individuals at end of life and make sure that we're delivering national best practice. What we've undertaken at a Devon level is an end-of-life commissioning review, and we'll talk a little bit around some of the recommendations that have come out of that. But one of the key ones is around making sure that we've got a single service specification that's equitable and the same across Devon, that kind of sets out those key standards that people should expect from the services that we're offering and commissioning within Devon. We've got that equity of access, and that individuals are receiving the right level of experience. There's also some work that's been done through looking at patient safety events that have been reported to at an ICB level, so across Devon again, and that identified an issue with the administration of just-in-case medications. So what they did in order to address that rapidly was undertook a review of the processes in order to improve the literature that comes out with the medication, make sure that people are getting the right advice and the contact details provided to patients and families so that they know who to contact when just-in-case medications are required. Some of the other bits that the review has helped to highlight for us and where our commissioning intentions and our improvements are going to look over the coming year. So care home education is a really key area of focus for us. So how we can support further the rollout of education materials for care home staff and support staff training. Partners will talk a little bit around some of the offer that we've already got within Plymouth, but making sure that we've got that in a coordinated way that ensures that we've got equitable offer, and also that we're helping carers and staff within those homes to support individuals who will be at end of life. We also have launched a single NHS Devon end of life webpage, so that helps to bring together all the resources that we've got, describe some of the services that we've got across Devon. A big focus around ensuring that we've got sufficient packages of care for those individuals who need additional support at end of life. For some of those who've got primary health need, that'll be funded by the NHS. And what we're looking at doing is making sure that the arrangements that we've got support those individuals who might be in hospital and need a rapid discharge, so having flexible services that can step up and support those individuals where that's appropriate. And again, coming back to ensuring that we've got that in a personalised way, so understanding people's wishes and commissioning our services to support that in this so far as we can.
Alison?
Sorry, Chair. It's a quick question actually on both what's on your website, but also training and support for staff in their as they talk to family. A health power of attorney, in a lot of cases, could make quite a big difference to how an end of life journey is taken. There's obviously a small cost to that. Is that information made available to relatives and to patients early in the process so that they can make a decision? Because it's often the sort of thing that families won't broach with the patient, and therefore it's more helpful if an outside body do.
It's a really good point, and so we'll pick that up a little bit further on in terms of so we talk about death literacy and how we're talking more as communities and individuals about death and what people can do to help planning. So it's a really good point around the powers of attorney and making sure that you've got those, made your wishes clear, all of those kinds of things that absolutely as a community, that's more that we need to be doing, but also making sure that some of that opportunity around health professionals as well, our roles in making sure that all those conversations are being taken place at the right point, and that's everybody's responsibility. So that's something that we need to absolutely work on to make sure that we're improving those opportunities for them.
Patrick?
Thank you, Chair. Care home education, and this probably isn't just restricted to people on end of life, but all residential care home residents, that simple things like falling over and their ability for healthcare staff to pick them up generate default to the ambulance service. Now, I don't know, Chris, if this is around the protocol for lifting a frail individual in a care home setting, or whether there's not appropriate equipment to lift them. But that can't seem to be the right course of action, particularly if somebody is at end of life, that where they should be maintained in their care home with appropriate equipment to lift them, that it's default to the ambulance service. And then once the ambulance service attend, certainly from personal experience, they're carted off to hospital and might sit outside there for hours waiting to get into A&E. Because the medication may be on a blood thinner, and the protocol is that if you're on a blood thinner and you've fallen over, you might have bashed your head, therefore you need to go. So this whole thing does need proper, and I would suggest quite urgent attention in terms of the guidance given to the ambulance service and other healthcare partners. So if I hone in on equipment, so does NHS Devon provide any support to care home owners in the provision of appropriate equipment? And if so, do you believe there's adequate provisioning care homes in Plymouth?
So picking up the thought, I know obviously falls is just one component, isn't it? But it's a really good example in terms of it's an area, as you described, Patrick, that we know that drives activity into the emergency department, actually how we can support more people to remain in those homes where it's non-injurious and it's appropriate to do so. So we've got a big programme of work around that at the minute, working with a number of care homes to identify, understand the reasons and look at how we can wrap around support, improve training. We've bought some equipment, has been provided for some of those homes that helps lift those individuals up where it's appropriate. So we've got a real focus around that at the minute. I think in terms of whether there's sufficient equipment for everybody, well, that's one of the things that we need to look at. So there's been a programme of work to look at individuals who've come from care homes into hospital. There's been some really rich information that's come out of that that's enabled us to focus some of that work. But we need to do more of that to make sure that homes are supported, because equally they, where it's appropriate for those individuals to stay in the care home, it's better for the individuals. The homes want to support those individuals too. So we just need to make sure that we've got the right wraparound services to help them do that.
Thank you, Chair. And maybe something we want to pick up on a recommendation at the end in terms of some sort of audit of our care homes in Plymouth and their suitability for dealing with these sort of situations. So don't forget, just flag that and come to it at the end, please.
Okay.
So next, there's some system-wide projects that we'll talk through later. So I won't describe too much detail at the moment, but around treatment escalation plans, advanced care planning, again, coming back to the care home component and how we support those, making sure, again, that staff are confident to have some of those conversations at an appropriate point and as early as possible. There we go, we talked about equipment in terms of making sure that we've got the appropriate equipment around end of life that supports those individuals wherever they are in order to help them to do so. I'm going to hand over to Jane to talk a bit about the national framework.
Sorry, Chris. Sorry.
That's fine.
Sorry. I just want to pick up on the TEPs, the treatment escalation plans, and I've had an issue with TEPs before, and when do you involve families with these TEP forms, or when do families get involved? Because there's been a situation where a TEP form has been filled out without the family being there, so we're not aware of any TEP form being in place. So I'm kind of like we were saying about an ETEP now. Would the families be involved in this? And I know you're probably going to say they would probably be involved if the person in question had dementia or they couldn't make decisions for themselves. But when is it decided that that person can't make that decision for themselves? Because in a situation where somebody had the onset of dementia, but because they could tell you what they had for tea or that they wanted for tea, that was classed as actually being capable of actually filling out the TEP form themselves without the family being there. So I'm kind of like a little bit worried about these TEP forms.
Shane, I wonder whether you might be able to respond.
TEP forms remain a medically led decision with input from the patient and family. So that would form part of the very baseline of good practice. So we know from our very recent trust-wide TEP audit, which is the first trust-wide TEP audit that we've done with medical school colleagues, that we're not always hitting the mark in terms of the quality and what we should be getting from TEP forms. And that leads into some of the work we're doing around ETEP, because that will enable us to audit, it will enable us to track back some less than perfect practice to our colleagues, so and do some education and support. So we would always be looking for family and looking for family and patients to be engaged with that where appropriate, but it's not a patient choice that a TEP, the TEP decision is not a patient choice in terms of resus, but actually TEP really forms part of early conversations around advanced care planning too. So that document allows us to have a conversation about what happens later on in that patient's journey. So it's with some of the other work that we're doing around education, we know that we need to really home in on TEP and the quality of TEP, because it will knock on to so many other positives in patient journeys later on. But I absolutely acknowledge that the quality of TEP isn't exactly where we need it to be across the system. But ETEP is a massive step forward for us in terms of how we manage that better for everybody concerned.
Thank you. I mean, the TEP forms do worry me, if I'm being totally honest, because there's been cases where a TEP form's been filled in and an ambulance has been called, and ambulance crew have said that we're not taking this patient in because they got this on this TEP form, but it was maybe nothing to do with what the illness was, and that is a major problem, because obviously they're refusing to take this patient in because of whatever reason, but it's nothing else to do with what, and they're having to phone through to see if they could get permission to bring this person in because of this TEP form, because they're afraid that they're going to be in trouble. So I am really, really concerned with these TEP forms, because I don't think they're actually being used as they should be used, and that does worry me.
So I think this also, Chair, expands to the wider programme of support, because the TEP provides an element in terms of that care plan, but actually how it links to comprehensive geriatric assessments that take place, advanced care planning, but also how we're supporting our crews when they are out at scene with an individual, with support around specialist advice. So we'll talk a little bit about our support in ED, but also we've got a new care coordination function that's been commissioned across Devon that allows crews to have phone-in support to an advanced care practitioner and a GP to be able to support and discuss through in terms of the ETEP form, as well as the quality improvements around ETEP that this new programme of work is doing, to make sure that we've got education about how ETEP should be completed, and with our wider professionals who then use those to make sure that they understand what it's saying and what it's not saying, and we've got the specificity in there as far as possible. So I think we'd all absolutely acknowledge that ETEP programme has been on a journey. It needs to be really importantly documented for individuals and professionals in terms of how they're following that, but the support that goes around it is just as important, I think, as the ETEP itself, is what I would emphasise.
Just one more thing that I don't think is reflected elsewhere in my short presentation is around the training we're doing around non-medics completing TEP. So traditionally, medics would just complete that documentation, but actually we recognise that there are other specialists across our healthcare system which might fall under the MDT banner of nurses or AHPs who are well placed to complete that documentation to a really high standard, perhaps because the doctor hasn't got enough time, or actually they know the patient better. And as a system provider, St Luke's, Live Well, and now UHP, we're all running independent programs around non-medic TEP training. So there are more people out on the ground who can ensure that these TEPs are much higher quality than perhaps, or what we're finding at UHP is that those people that we've trained so far are actually finding TEPs that aren't such great quality and actually redoing them, which is a real, I think, is a real bonus, for everybody concerned. So that's been quite a big project for us at UHP, and we've piggybacked off some early work of St Luke's and Live Well to bring that to fruition.
John?
I mean, I'd like to support what Paul Eder said, because I had a cousin 5 years ago who had a TEP form signed up a year before I knew. In fact, I didn't know until she was very ill with, she was 90 something, was dehydrated, and I wanted her admitted just for a bag of fluid, if nothing more. And again, late at night, there was fairly unpleasant sort of, because the ambulance crews wouldn't take her because this TEP form said she didn't want any intervention, including fluids. And I didn't even know until that day that it had been signed up, even though I was the next of kin, saw her several times a week. Practice knew I was the next of kin, and it had been signed up, and I had no knowledge. She was in a care home, obviously. So it does happen. And, maybe things have improved. Maybe it was just an oversight, but, it is a worry. I think we do want TEP forms signed up because we don't want people transported to hospital who shouldn't be transported when they should be able to die peacefully at home or in a nursing home. But, there has to be, the knowledge has to be shared, I think.
Anybody else? I mean, we just carry on with.
Okay, thank you. So this is just highlighting the national framework. So there's kind of 6 pillars within the national framework. So this basically, we assess ourselves around these pillars. They've been in place since 21. We did a local assessment not so long ago. But we are hoping in the next year or so to try and repeat that and really see, where we're doing well and not. So one of the things as well, for all of us, what does good look like? And we keep asking ourselves, what is the main things? So the 4 things we've kind of looked at is the preferred place of death, which we've already discussed, can be tricky. Identification, so really making sure that we've got an end-of-life register that's visible and is fit for purpose. Coordination, as Rachel's mentioned, having advanced care plans kind of discussed with patients and their families, making sure they're visible throughout the system and they're used, and also that there's care and support in those kind of final stages in the preferred place, so that, as you were saying, John, around making sure that people have got access to IVs and things like that, so they don't have to come into acute settings to have things that could be delivered in home. So that's what we're looking, so those are our kind of vital signs, and that's what within the Southwest we're looking at those kind of 4 different pillars. So it's through this Southwest End of Life Network, and it's an NHSE run programme. So they'll be taking the temperature of the system, and they're kind of putting in kind of 3 measurable things. So measuring the health of our end of life systems, and then there's 3 core measures which they're putting in place. So recognition, which is going back to the identification of the it might be their last year, asking that surprise question. So within what we've talked about, it's mentioned the gold standards framework. So within the gold standards framework, it asks a surprise question. Would you expect this person, would you be surprised if this person died within the next year? And then there's a kind of domains it goes through for people to really understand that.
Alison? Thank you. On this point, recognition, I'm identifying patients who should be on the register or are at the point where they ought to be on the register. How do you cope with a patient who is sort of completely in denial and doesn't accept, but the family are in a different place? Does it have to come, does permission to go on the register have to come from the patient?
I don't know the answer to that one. Does anyone else? I think I don't know actually. We can get back to you whether you need permission to go on the end of life register. I mean, it is something that's a clinical record, and it sits within the clinical record. So I think the whole point of it is to make sure that people within the system know that this person's coming towards the end and recognises that. So my assumption is wouldn't be that you'd need permission, but I can check.
No, if I can do a supplementary, I mean, it is interesting. The example I have is it's a close family member who, right up to the end, was basically, I'm not dying. I'm not going to need any care. No pain, nothing. And it ended up that the young members of the family were having to wash, clean. He got doubly incontinent because he wouldn't accept he was end of life. But I didn't get the impression that the family felt they could get him onto that and perhaps getting him onto a different pathway.
It's very tricky, and a lot of it comes down to capacity, doesn't it, as well, and having those tricky conversations. And I think that's where that end of life recognition is very tricky. And if we really need skilled professionals out there doing these conversations. So yeah, I totally agree. It can be tricky. So that's the first bit, is really looking at the recognition. What does our end of life register look like? The second thing is looking at the experience. What are people, if they are on the end of life register or receiving last days of care, how's the experience, and looking at the experience metrics that we've got in place through UHP, and then also looking at the activity. So those are kind of 3 different domains of area, and that's what we'll be looking at over the next year. So I think I just hand over now to Rachel and Shane. So do you want this slide?
So if you can drive, I'll just introduce Lovely. So I just wanted to begin with absolute recognition that we know for people in those last few weeks and months of life, and not least on the days of life, we have one opportunity to get that right for that individual and their families, and with that comes a huge responsibility, but also I think drives us in terms of all of our improvement work, both as an individual organisation but as a system amongst that spectrum that Chris and Jane were describing, that we take every opportunity to do that in the best way that we can. That said, I do want to acknowledge that there are times that we haven't got that right for the reasons that we've talked about, whether that be the capacity to meet people's wishes fully, for where people's needs may change and how we can support that. and also in terms of some of the pressures of either capacity or demand that we may be facing. And for those that we haven't got it right for, I do want to apologise on behalf of the system where that hasn't happened. I think that's really important that we say. But also what I'd like to describe is for all of us in the work that we're doing, how we are talking to our families, talking to those individuals, reflecting on those experiences, whether that's through quantified or qualitative information, to get that right and better next time, and to continue to improve, and what we would want for ourselves and what we would want for our loved ones. And certainly from a UHP perspective, there was some work that came through our medical examiners. We saw a increased number of complaints, predominantly in relation to individuals who had a death in our emergency department, higher than we would expect. And that led to a review through our mortality group and a specific priority paper that went to our trust board to reflect on the fact that we weren't getting that right and what we needed to do in terms of processive improvements to do that better, where people weren't able to be supporting the community and they were under our care because that's where they had presented. And that's the improvement work that Shane's going to describe with you that we are taking forward, and what we've delivered so far, notwithstanding the fact that we've still got more that we can do as an individual organisation, but also as part of the provider network that are here today to talk about our end-of-life care. So I'm going to hand over to Shane to talk through a few of our improvements and the journey that we've been on, of which that data spoke a little bit about. We are seeing improvements in individuals dying at home or in other settings compared to the hospital, but we've got further work that we can do. Thank you, Shane.
So just roughly split into kind of three parts. Just wanted to talk about our core service in the hospital, and latterly go on to maybe some of the gaps that we know that exist, and how we're addressing some of those gaps with projects that have gone live over the last year and over the forthcoming months. So our core service in the hospital is provided. Is commissioned by the hospital and provided by St Luke's Hospital Specialist Palliative Care Team. So they're very much our resident team within the hospital. Really, really positive feedback and a well-integrated service in the hospital. And they provide a specialist advisory service across the hospital. And as an average, 138 patients die in the trust each month. The hospital palliative care team receive between 120 and 140 referrals each month, and they have around 50 to 70 deaths. The split between cancer and non-cancer, it's something we're very much looking at, because that impacts on the kind of work we do and how we support patients. So that team is roughly 52% non-cancer and 48% cancer patients. So it's just what we're seeing is a much more complex patient in the hospital. So whilst we're seeing a gentle decline in the number of deaths at the hospital, that patient is more complex and needs the right support and the right advice at the right time. So just moving on from there, thinking around feedback that we get around our bereavement survey, and I just kind of included some positives, and I think it's important for us to appreciate that actually our workforce are really committed in the hospital, and actually in many occasions, we're getting it really right. It's not to say that we get it right all of the time, but as we can see, just over 94% agreed or strongly agreed that they were shown respect and dignity, and 83 and nearly 84% regarded their care as excellent or very good. So I just wanted to touch and recognise a lot of the really good work that is going on in the hospital by really committed colleagues, although I absolutely appreciate that there's an opportunity to do better. Just moving on there, Rachel. Thank you. So issues and opportunities. As Rachel already mentioned, there was an escalation in terms of the number of deaths in our emergency department, and notable complaints around some of those deaths. in our locality in 2022, 51% of those who died in hospital, and we've seen that reflected in Chris's figures earlier. We know that earlier recognition reduces unwanted or unneeded interventions and can facilitate much better outcomes, and we know as a system that we're concentrating on that. I think there are opportunities for us in the hospital as well around making sure that people have the right space, around their dying process, and that kind of links into some of the developmental work that we're looking at. We can't always provide that kind of side room space for patients, and that was reflected within the coronal kind of deaths and some of the infection control issues we've had around being able to facilitate side room space for people at end of life. And again, that links into one of the projects that I'll come and I'll talk about in a minute. So key actions and projects and providing an opportunity for change. So we've already touched on the electronic treatment escalation plans, which as a system we are looking to support, and that's rolled out across UHP last week. I'll talk briefly about our Mount Gould end-of-life beds, and that very much speaks to that dedicated space for people at end of life to have somewhere that's a little bit quieter and more suitable for end-of-life care. The emergency department end-of-life practitioner role, and latterly a small team which we're very much developing. Quite happy to take any questions as we go, or
Zoe?
I just want to understand 31% ward death. I mean, that's a high percentage of what? What is, like, I'm struggling to understand how 31% end of life are dying in a ward and not a side room. If you could just help me with that a little bit, because it's quite hard, isn't it? Because,
yeah.
I mean, death is the only certainty in life, and we're all going to get there. So I would like to think that it's better than that.
I would agree with that sentiment. I think there are absolutes in terms of space that we have available and prioritisation in terms of infection control and looking at the bigger picture in some of those environments. And also when people become acutely unwell, moving people around is we often don't want people to be dying as they're moving from place to place, moving from different places within the hospital. I think that's difficult. I think that the project that we're looking at looks to address some of that in terms of the Mount Gould end-of-life beds and potential expansion of those beds. But I would completely agree that that private space should be something we ought to be making available to those patients where we can.
And there are for some individuals, because of the nature of the organisation of UHP, where their needs may not be able to be met in other settings. That's not saying that's the norm by any means. Part of the work that we've gone to around the Mount Gould pilot, but the work we're doing with the locality is actually looking at understanding the numbers of individuals that die within an acute setting, what proportion of those could only have been supported in that environment and that care that we've got. But for those that we could meet elsewhere, what does that demand look like? What does the number of people we would need to support to inform that commissioning plan in how we take forward our model of care for end of life, so that we can assess that in the types of numbers that we would want to be supporting as far as possible out of hospital, where that's that individual's wishes, or certainly in a much more holistic environment in the community, rather than a busy ward and acute space where we can't meet the whole of those holistic needs. So it's a consequence of some of the needs where we can only meet it, but also where we have got that lack of wider provision of alternatives for those individuals currently.
Can I just add, those figures might improve if tests were done quicker within the hospital. So MRI scans or CT scans or brain biopsies or whatever that person needs. If that was done in a reasonable time, we might not have patients that are end of life in the hospital, because those tests would have been done quicker. So there would have been maybe a choice for that person to maybe go home or to go into St. Luke's or wherever which they feel comfortable. And I think you really need to get to the nitty-gritties of why we've got end of life in hospital. Why is this happening? And I think if you drill down to it, it's because things are not getting done quick enough in the hospital. And until you start addressing that, these figures are not going to go down. And that is from a personal point of view. And maybe I shouldn't be making a personal point of view on this today, but I'm listening to what you're saying. And until this gets addressed, none of this will improve. Patrick.
I've got some sympathy with you, Pauline, having sat for 3/4 of an hour outside an X-ray facility on Sunday when the person I was trying to track was elsewhere in the building. And to be honest, whenever you enter the hospital site, and don't take this personally, you're just a cog in a system, and it's very, very difficult. It's a bit like any of you coming into the dockyard and being sort of immersed in a massive organisation and not really getting very far. As a citizen going into the health service, it's much the same process, and it is quite frustrating. And when people say, well, you could have logged on Wi-Fi, well, I don't, lots of the basic requirements. So how do I plug in my mobile phone because it's dying, and I can't get reception in a ward that. So there's huge issues for people that use the hospital system. Having said that, though, I do commend all those healthcare professionals that are dealing with very difficult end-of-life situations that are here today. It's certainly something I would struggle with personally, and I'm very grateful that there's, a whole army of healthcare professionals that deal with these difficult situations. Just a couple of points. The point that Zoe raised, I think, in terms of the 10-year rebuilding programme at Derriford, is the end-of-life needs that are currently being experienced are they influencing the rebuilding programme? So the point that Zoe makes, many of the wards at Derriford, the side rooms, they're minimal compared to the ward capacity. So generally, because we've got perhaps more in Plymouth going into the hospital setting and passing away, it's aggravated by the built environment of the hospital. So it's important as we remodel the hospital in the next decade that it takes into account perhaps the need for more individual rooms rather than just a capacity that's greater in a ward configuration. So that's one point. And the other point I wanted to raise, and sorry it's going back a slide, but in terms of the feedback survey, was a question asked of those who are asked to complete the survey of whether their preference would have been for their relative to have passed away in a different setting to the hospital? And if so, what were the statistical results from that question, please? Thank you, Chair.
Can I answer just in two parts? Is that okay? So for me, as the lead at UHP, we ought to be looking at identifying those people at end of life and enabling them to be looked after elsewhere in the system. And whilst I appreciate we need additional capacity for side rooms for those people at end of life, actually the challenge for us is working with system partners around actually identifying those people in the hospital and having routes and pathways in order to get them out at the right time so they're not at risk of dying en route, or actually it's early enough so they can have a settled death wherever that might be. So whilst I appreciate end of life being incorporated into any future planning, what we are doing is working with colleagues around identifying dying earlier, and that's what we need to do as a system and as a UHP system, so as a wider system and UHP, and that's something we are focusing on. We're focusing on education. We're offering increased cultural change around talking about death and dying and enabling that conversation. So I just wanted to respond to that element, and also in terms of your second point, just remind me of your.
So on the survey, so those trusted carers bereavement survey feedback, was a question asked about so these are people that relatives have died in hospital. Was a question asked in relation to would they have preferred their relative to have passed away at home, in a care home, or in a hospice? Was that sort of question asked?
That particular question is not asked within that survey. It is reflected in other documentation across our system in terms of preferred place of care and preferred place of death, and that's something as a system we should be focusing on, focusing on more. However, in terms of absolute choice, there are difficulties there also. It can't always be facilitated, so it's not always possible to enable a death in because of wider implications.
I think the problem is, Shane, when you're in the hospital system, and again, apologies, I don't want to, this isn't directed at individuals, but it's a bit like a prison, and that you've got to try and break out the system, and you're only as good as the advocate advocating for the person. Now, I'm sure my mother wouldn't mind just, she went in with a virus, and she was in hospital for about 3 months, and I basically gave the consultant an ultimatum that trying to get to the nth degree from a clinician's point of view, her general well-being was deteriorating. And so it was like, if you don't, I'll give you a day to complete the test you want to do. You've had her 3 months. If you can't complete, she's going home. Now, there are lots of people in the system, I haven't got anybody to speak up for them. And I already had an argument with the consultant who didn't want to speak to me. So, ultimately, it's difficult for lots and lots of people. Now, probably all of us in this room can actually advocate, but an awful lot of people can't. Yeah. And the problem is, in a clinical situation like this, it's all about saving life. It's not about managing the end of life. Even though you're all involved in it, a lot of healthcare staff aren't, are they? And I do generally think a question should exist. And again, Chair, it may be a recommendation from this panel that we should actually understand those who unfortunately have passed, their relatives are passing away in a hospital setting, how many of them would have preferred an alternative situation? Because some of them probably would have wanted to have passed away in hospital because they were probably thinking they would get the best treatment. But we all know that actually it may not be the best place for them to end their days. And I think that ought to form part of the survey for those that pass away in hospital. Thank you very much.
Yeah. Just a couple of broader points. It may be helpful to members that Derek comes back to talk about the improvement work more generally around our internal processes, around our support to facilitate more people home sooner, working in combination with Gary and Chris around that, and also our work around our phase 1 programme, because you're absolutely right in terms of the size of the hospital at the moment and the challenge it has with that, both in time to diagnostics and in terms of it is extremely challenging. There's work we're doing with our regional team about how we can do that better, but part of the new hospital model is also around how we can facilitate greater more ambulatory pieces of work where people may come in if they're frail, they may need some obs and support, they may need a 24, 72-hour stay, but then we're using that time to facilitate those individuals home. But I think, as Shane mentioned, really this pathway and this spectrum is to, with an advanced care plan, that we can do as much as possible to support people in the community, whether that be in their own bed or a care home bed, and the support is wrapped around those, and we've got their specialist advice within the acute sector should they need it, so those teams aren't felt alone. But that's, I think, the bigger transformation of care as a locality we need to make over the course of the next year.
Will?
Just going back to some figures you mentioned just now, a palliative care team, I don't think they're on the slides. You said about 150 people a month are seen by the palliative care team, and did you mention 70? About 70 of those passed away in the hospital, and use the terms cancer and non-cancer, and that being about 50-50. So when you read around about palliative care and people talk about different causes of death, and you look back on the previous slides there's quite a lot, there's those certain conditions, and working in a hospital there's certain wards where more people seem to pass away. That's anecdotal, but so people, when I've been reading around palliative care, cancer patients, maybe they're taking on a bit more of a journey, and the family and the carers are more clued up on what's likely to happen, whereas other people with other conditions aren't. So how does your palliative care team should some effort be looked at the non-cancer patients to see if they can have the same quality of care that some of the cancer patients have regarding to palliative care and end of life?
Just in response to that, we talked about the surprise question earlier around would you be surprised if this person dies in the next 12 months? That question is much more reliable when we're thinking about a cancer cohort as opposed to a cohort of people that might be heart failure or another non-malignancy. And I think we're seeing those figures move recently, and that will be the challenge moving forward as to how we engage with that cohort of people. And I think it brings us back to something that was mentioned earlier today. For some of those patients, they don't necessarily recognise themselves as end of life. So that person with a heart failure almost is thinking about that as a long-term condition, as opposed to something that actually they might die from in the next 12 months. And I think that's our challenge, is around reaching those people, spending time with those people and helping them understand where they are in terms of their journey, and that takes time and resource, and that's why we need to be looking at engaging with those people in terms of pathway management and support and care.
I was going to add, it goes back to the care plans, actually, how for those that are at long-term conditions, particularly with frail, we've got that care plan that monitors what their needs are now and how those change, so that then it gives almost the right junctures at the right time, Will, for those broader holistic conversations around dying matters and preparing people for death, not just the individual but their loved ones, but that they're, and we're going to have to learn, I think, with the new process that we've got around those care plans, and keep asking ourselves, are we getting it wrong? What's the feedback we've had from families and carers, so that we evolve those processes as we learn.
Alison?
Thank you, Chair. Obviously, the hospital's been under an awful lot of pressure. It's been critical on a number of occasions, and therefore I'm assuming that there have been more deaths in the emergency department as a result, and these would have been deaths, end-of-life issues, which people hadn't either wanted or planned for, and you probably on the day couldn't do anything about it because there simply wasn't the capacity in the hospital to take those people to a different room, to a different space. And so the bringing experts into the ED department is a good thing, but it's a physical space issue. And that in turn leads me, that's sort of setting the scene from your perspective. But we've got these figures that show very clearly that more people in Plymouth die in hospital than die at home. And I suppose my question is, and you've partly answered it in some of the things you've been saying, is what are the blockages? Are we asking the questions early enough of those people so that you don't actually have to scrabble around when they turn up in the ED department to try and find out what's needed and what the capacity is? Do the families know they can have a hospital bed at home? Do they know they can have pumps and medication done at home? Because in a lot of cases, I don't think people do. And so they do end up at the ED at the last. So any comments on that, please?
I just want to hold that for when we have our community and St Luke's conversation, because I think broadly, as Chris mentioned, the definite work that we need to do is to make sure that we've got the right capacity in place that can do that earlier and can meet that to the level of threshold that's needed for those individuals, and certainly that care coordination model that I described earlier can be that support and guidance to help facilitate that coordination, and that's the next stage.
We are looking and further considering specialist provision around conveyance too. So very often it will be that decision making around where somebody is in their journey that can potentially be supported remotely, depending on what that team, whether it's an expanded ED end of life support team or support elsewhere in the system, and that's where we need to focus, because very often our clinical colleagues will default to actually preserving and treating, and actually the really difficult part of that is not the do nothing, that's not what I mean, but it's the non-active treatment option, which is the which is the more challenging decision to make. And I think that's where we need to be looking to is providing support elsewhere to take those brave decisions and ensure that people are supported in that decision making.
Absolutely.
I think mine just follows on from what Councillor Rainsford has just said, thinking about not going into hospital, but those that are at home, and where we're saying some of those will be then transported into home, but some of them won't be because they don't want to be in hospital, but actually what provision is being put in. You said just before about sort of not just sort of keeping them going, but where you've got one condition, for example, heart failure, and then the GPs not actually doing anything to support that end of life. So actually, therefore, making the whole situation, a sort of a double whammy, because you've got the heart failure. GPs have sort of given up. Oh, you've got heart failure, so you're going to be going, no surprise if you're going to go in the next 12 months. But actually, there's other conditions that are still going on, and making sure that support's in there so that there is a good death rather than a not particularly pleasant death. And I think there's a lot of work that needs to go back, and I think it needs to go back to the GPs and the amount of communication and the amount, to make sure that actually you've got the right pathway and you've got the right support and treatment in place, rather than it being literally in the last couple of days when it's basically too late and not very pleasant.
Zoe?
Yeah, I'm really sorry. I'm really struggling. It's quite sad, actually. I'm really struggling, and I knew that coming in here today was going to be a difficult conversation because of what it is. But I've not had anyone die, and I've had to sit around their bed, and I'm finding this really difficult. This data's so vague. I don't understand anything that I'm looking at all. And all I keep hearing, I've written it down several times, is we know it's not enough. We know there's more to do. We're looking at this and we're looking at that, but actually 31% of people dying in a ward, 31% of people dying in a ward that could be given the opportunity to go home is really bad. I think that's really, really bad. And I just think it's really easy to say, and I recognise how hard your job is, and I recognise how hard everybody works in this. But these are people's mothers, brothers, sisters, fathers. It's really, really important stuff. And I just don't understand the data that you've given us today. I can't get my head around any of it at all. If you understand that, sorry.
So I really appreciate how emotional this is. So we'll talk in a moment around what we are trying to do at UHP to provide a better setting, so it's not on a ward, but it is back to that range of services that we can provide, not just when an individual is in hospital under our care, but also earlier in terms of that planning, so that can be in a much more planned way around how their wishes are met. And that's the significant programme of work that, with the commissioners, we're all committed to do to get that right. And not just now, but because we know that we are going to be seeing an increasingly aged population, where we'll see greater demand for a good set of services when an individual will be at end of life, and how we can develop that now in line with that capacity. But that's probably one for a broader set of conversation from the panel. Perhaps we pick that up broadly at the end in terms of what next and how do we do that better.
Again, I would mirror, no, please don't. I would mirror everything that Rachel's just said. And I think that very much, when I put this together, it was around laying out the fact that it isn't perfect, that it's not right, but actually there are some really significant pieces of project work that we're working with St Luke's and we're working with Live Well and Marie Curie that are really impacting patients' experience of death and dying at UHP. And I think that's the bit we haven't necessarily come to yet, and haven't necessarily reflected all of the work that's currently being done around discharging patients home via the urgent care end of life service with St Luke's, going home with a package of care, going to the inpatient unit at Turnchapel, or going to our Mount Gould bed. So there, it's not a finished piece of work, but we are managing to get that right for a significant number of patients, but that needs to be better. So that hasn't necessarily been reflected so far, but I just wanted to.
I just wanted to say, Chair, that there's a lot of information in this, and there's a very small period of time to be able to digest everything that's in here. I just think maybe we need more time, if that's okay.
Gary?
Thanks. I just think, Councillor Riley as well, just wanted to acknowledge this is a really big and difficult subject, and actually the answers are varied and complex across a huge system. And I just wanted to touch on your point, and I think what we've heard so far today, and hopefully we'll hear about some of the other plans, is sharing those numbers about the numbers of people who are dying in hospital, about others. I think it shows that there is an issue there, and I think people are trying to acknowledge that that's not right, and I think you're really agreeing quite strongly with some of that. And I think hopefully when we get into some of the planning, what you'll see is some of the efforts that it will take to move that number from that place where it isn't right. That leads to some of the other things we've heard about today, which is then unfortunately some people aren't having that privacy inside of the hospital for that life event that we would all want. The solution is to get people to the other places, not to just build the capacity into the hospital. But it's such a varied and complex answer. And I think what I would hope that we'll hear a little bit later from people is around some of those initiatives and some of those schemes which are going to help support move that. One of the things people wanted today was to get some of that acknowledgement about some of the issues, as well as to celebrate actually some of the success that goes on. But it's tough to hear, isn't it? Because this is not, we all want it right for people. And I think hopefully as we move through the presentation, what we'll get to is some of those things that people are going to work on to move that to a better place so that more people get a better, the right experience at that moment of their lives.
Thanks, Gary. John?
Thank you, Chair. I think Gary summed up some of the things I'd like to say. I mean, where you die is different people want to die in different places, and I think the worst thing is shunting people either into hospital when you know they're going to die, or actually sending them out of hospital when they die almost immediately. So, it's a question of where people are when the decision is made they're probably going to die. Generally, with older people, we must endeavour more not to admit older people who are not going to benefit from hospital treatment, but actually, need to die peacefully wherever they are, at home or in a nursing home. That's what we need to do. And similarly with private rooms, I mean, if you've got a big family, yes, it's very nice to be in a private room if you're dying, but if you're on your own, actually a side room is possibly not the best place. You want the nurses to be nearer, just go and hold, it is not the same, I think, for every circumstance. And, it's a bit like childbirth. Everyone knows what sort of childbirth they might like to have, but whether you can actually have it in the end depends on logistics and circumstances. And it's a bit the same with death. It's not entirely predictable or plannable. So I think it's not going to be ideal for everybody all of the time, but we've got to actually make it more ideal for more people more of the time.
Okay, we're going to move on now. Is that okay? Thank you.
So we've seen a substantial increase in the end-of-life education across the Trust, and that's been kindly funded by our St Luke's colleagues, a 2-year fixed-term contract, which is really in recognition of some of the work we've needed to do probably post-COVID. We've seen a huge number of staff kind of change role and move around the hospital, and actually that's about re-embedding good practice across the hospital around recognising dying and supporting a good dying process. The 100-day challenge, which certainly UHP aren't responsible for, it's a system-wide project around supporting care homes to help patients stay in their preferred place of care, and that project has been responsible for making recommendations around how better to support care homes, and also recognising what care homes feel they need in order to support patients in their normal place of care. and reimagining. Recently, that the hospital has reimagined the governance and committee meetings and brought a larger spectrum of colleagues to that table around looking at what's going on in the hospital and working as a system to improve care and improve outcomes. So those are some of the projects that I wanted to kind of talk about and mention at this point. I do want to talk about the end-of-life ED practitioner role, and that inception in April 2023. And I think this goes back about 18 months when a colleague of mine submitted an application to Macmillan Cancer Support around kind of pump priming a project to provide an end-of-life specialist just for ED. And with a little bit of alteration over the last kind of year or so, we managed to get that person in post, and they've had a massive impact in terms of helping patients, be in the right place at the system, helping people, be turned around appropriately in ED, or streamlined through to the right place in the hospital if it's around further investigations or looking at reversible issues for their healthcare. So that post has supported 167 patients so far. We're talking about treatment escalation plans a little bit earlier, so 128 treatment escalation plans updated, and only 13 of those people out of the 167 actually died in ED. So where that member of staff is coming into contact with those people, they are being helped to be looked after elsewhere in the system. None of this role is possible without the support of St Luke's and Live Well and Marie Curie. So it's very much a system-wide project which one person's sitting in the centre of. Latterly, we have managed to obtain some money to increase, so to double the capacity in the department in order to support weekends and extended hours. So that will provide a partial, it won't provide a complete 7-day service on 2 members of staff, but it will provide 3 weekends out of 4, and we can test the concept around actually weekend coverage and whether that meets the needs of patients. We've also put in a Band 2 Marie Curie support worker who very much is providing that hands-on, being alongside patients who could be at end of life in the department, needing hands-on physical care, whether that might be mouth care or turning, and that's really about being alongside people so the end of life practitioners can go on and help other patients potentially in ED. So that has been a really positive project and has helped people move away from ED. If some people will need to come into ED and they will need blood tests, or they'll need scans, or they'll need an X-ray, etc. And actually, what this person's been doing is facilitating that and helping them move out of the hospital quickly, so they don't get caught up in that. They don't get caught up in the UHP system and gone off onto a ward, and then they never potentially come out. So
just emphasise, although they're based in the ED department, they're almost looking outwards of the hospital, though, to almost in the conversation we were just having is, if there has been an individual that's been brought into the hospital, we've got another opportunity actually with our partners to connect and coordinate that care, to consider the other option that are available. And that's why you see some of the data that's showing the number of deaths that have reduced in the department. There's an absolute correlation to when this role came in, and that wider connectivity we've got with the provision. You'll hear a little bit about that from the individual themselves in a moment, which I won't, because I think in her words are really powerful.
The other very significant project that links to that role is our Mount Gould end of life bed base at Mount Gould. Very much we've taken very tentative steps, and whilst the numbers aren't a massive number of patients, we have moved very slowly because potentially we must make sure that the right patients are looked after on that site, and we're not getting it wrong, because actually getting it wrong means that perhaps there aren't the right skills in order to support patients, or potentially that might lead to a difficult death. So we've had a very stepped and slow progressive introduction of those limited number of beds, but actually that extrapolates into a very significant number of days where end of life care has been provided inside rooms, away from the main site, to a site that people can travel to much more easily. No ward times. So it's proved the concept and provides a base for us to build on and expand on moving forward. But 60 patients have been supported. What feels really important as well is, whilst we might recognise that someone is dying, if something changes and actually that person actually has rallied, we want there to be an opportunity to say, something's changed, you're doing a lot better than we thought, you've benefited from care and support. And actually 9 of those patients have gone on to be discharged elsewhere in our care system. And that feels really important and reassurance to me that those people are continuing to be reviewed and supported elsewhere where appropriate.
And I just emphasise this is part of a blend of opportunities and places for us to care for those individuals. It's not replacing some of the excellent support that we have at St Luke's or we have at home, but it's actually for that cohort of individuals that needs have been identified, that we aren't quite meeting those needs right in terms of those being on the ward, and it wanting to be a much more holistic setting. Part of the work we're doing around the identification within the hospital is also just looking, is there a wider population base that we need to support in this way? So what's the right configuration of bedded to non-bedded support that we need for individuals? But this is early days in collaboration with partners around that blended model. Should we hear from Ali? I'll do my very best to play this now. Oh, can you? Oh, perfect, lovely, thank you.
In April and describe my starting as sort of hitting the ground running, really, because it became apparent that the sheer busyness and treatments that occur in ED, it's not the right environment for anybody to die, really. So it was really important that the role acknowledged that there had to be alternatives, because we only get one chance to get end-of-life care right. So the purpose of the role for me is, like I've said, making sure patients die peacefully, making sure they die comfortably, but fundamentally making sure they die where they want to die, their preferred place of care, their preferred place of death. And that's taking into consideration the relatives' wishes as well, because often the patients are maybe semi-conscious and they can't always tell me or express where that would be, but the majority of patients and their relatives don't want to die in an acute hospital setting. A lot of the consultants will say, and we've got our own end-of-life palliative care nurse and she'll come and talk to you. So I'll introduce myself to the family. I ask them about their loved one so I can get a picture of the person behind the hospital number, and I like that, what did you do for a living, it's obvious that you love your dad very much, what was he like as a dad, and we swap stories and we talk about, what they were like, and just sort of talk them through the process. It's noisy here, I've got alternative places, do you think, I think it would be much nicer for you to be there, and the families are very open about, the possibility of mum or dad or their loved one going somewhere else to die. I then talk them through what the stages are going to look like. But I ask, first of all, do you want me to talk you through what the end is going to look like as mum, dad, whoever as they're dying. Tell them that I'm going to be able to give them medication to help with that and reassure them that they're not going to be in any pain, that they're going to be settled if we can get them there. We also do a lot of cuddles, holding hands, talking about nice times to reinforce those positive memories, because it is so vital and crucial at that time that you at least try and attempt to kickstart a grief process in a positive way. It's just having that time, space and quietness, if you like, to take them out of that into somewhere where we can just focus on them and the person they love. And that, to me, it's an utter privilege to be able to do that. What a privilege it is to be able to, you know, do that for relatives. It's a joy to me. In order for us to facilitate that peace and dignity and quiet, we were able to work very closely with Mount Gord Hospital, where we've managed to have end-of-life beds there now. And the staff at Mount Gord have been absolutely phenomenal and have really embraced the challenge of looking after patients at the end of their life, in their last few days. And the location is beautiful. There's big, massive windows, it's bright, it's comfortable, it's very peaceful, it's very quiet, the views are very tranquil, and the staff have just embraced the challenge of looking after that sort of cohort of patients, really. And the feedback that we've had from patients being transferred to Mount Gord and actually dying over there has been really, really positive.
This is a fairly new thing that they're doing, is having a room here, and I can stay with him and they will look after me at the same time, which I can be with him all the time and I can do what I want. I can help look after him, but they're looking after me as well. They're feeding me, making sure I'm okay, and they've been brilliant, absolutely brilliant. Everybody on this ward is fantastic, from the cleaners right through the nurses, everyone. They all come in, make sure you're okay and everything. I cannot fault this, and I think it's a brilliant idea for people going through what we're going through.
Because we are 24/7, we can offer that support to them, and it's not just nursing support or doctor support, it's also emotional support, because we'll be all the time on the ward. So if they need us, if they need more medication to be given, we are here. Of course, for them, if they're being offered to go home and they are not ready for that, they think of what's going to happen at night. Although the team is out there and they can attend, however, they feel more comfortable to be with us because they know we are here. And the team really embraced that, this project. They really embraced it, and they feel that they're giving them those last days, they're giving them the best that they can. And they are there with the family and the patient. It's not just the patient, because the families are there and we have to be with them for all this journey.
Appreciate that brings a lot of emotions, doesn't it, in terms of for individuals. And I think what Ali's trying to describe, whether it's at Mount Gold, whether it's in the hospital, because for those individuals that's the right place for them at the right time, or whether it's with our partners in the community or at St Luke's, we want that experience to be the best it can be, and getting it right every time. And I hope through the course of the rest of the conversation you'll hear whether it's expanding that as a provision, or our advanced care plans, or our community offer that has exactly the same holistic focus on the individual and their families.
Would you like me to carry on, or do we want a minute?
Actually, I think we will. I think we'll have just a quick little break. because we're not going to get through all of this today, if I'm being totally honest. I think it's so much information, we are not going to get through this paper today. So I think we need to have a little break and maybe discuss how we go forward with this, because there is so much information here, and I think we wouldn't be doing it any justice if we kind of like, oh, I've got it on. If we try to rush this through, I think it really needs the time, and it's important that we give it time. So I think what we'll do now is we'll just have a quick 10-minute break, and then so if we're back by 4:10, that would be absolutely amazing, and then we can have a quick chat with people and see where we go forward with this actual paper. So okay, we're going to take that quick little break now.
it goes through.
Okay, well, welcome back, everybody. We needed just that little bit of a break. So we're just going to carry on, and then we'll probably at some point adjourn this meeting. We're not going to close it. We'll adjourn it and come back at maybe in a couple of weeks just to finish off, because it is quite quite a lot of information, and and members are quite enthusiastic and passionate about this, and I think we wouldn't be doing this justice if we tried to rush it. So I think it's probably the best thing for us to do. So I'm just going to pass the floor to you now, and we'll just see how we go. Is that all right?
Thank you, Chair.
Thank you.
So I'm Trisha Davis. I'm the recently appointed Director of Clinical Services at St Luke's Hospice. So I was the Deputy for 2 years, and we bring our own life story to it. You would have obviously been aware of our tragic loss of our newly appointed Chief Exec back in the spring. So for us as an organisation, we've also we've also gone on that journey in the last year, and I have to say, very sad at this moment in time, we've still not been able to have a funeral service or a celebration of the life of our Chief Exec either, because of the complexities around that. So it triggers lots of things for all of us. So as the hospice for this area, St Luke's is much loved and held with such high regard. I have worked in other hospices across the country, and I have to say, St Luke's is in its 42nd year now in Plymouth, and it's been an absolute pleasure as well as a huge responsibility to carry on that legacy and take over from predecessors because the hospice is held with such high regard in the community it serves. I'm just going to start with an area profile of the area we service, because you will see that is South East Cornwall. For this winter, to support South East Cornwall, we have offered a pilot to the 31st of March this year, offering an urgent care service, which Plymouth, we have been commissioned by Devon ICB to provide that service, and it has been absolutely transformational in giving choice and real options for people to remain at home for the end of their life. As with all things, it's a fabulous service, but we are very constrained by, we are a small to moderate size hospice. So when you think that we've even got 12 beds at Turnchapel, again, we've got 4 cars that we do an urgent, that we have out on the road every day, offering support and care runs to those actively in their last days and hours of life. We've been really pleased that commissioners have purchased a 5th car for us for the winter pressure, so we have had investment, but again, that within trying to meet everybody's request, that can be really challenging. So that's the footprint that we serve. It is the footprint of UHP, so that's known to us. I guess this slide, the real thing I just wanted to show was majority of our work, so nearly 60% of our work, is supporting people at home. When people think of St Luke's, they think of the site at Turnchapel. So every presentation and talk I do, that is really a fraction. That's less than 10% of the work that we do. It takes a disproportionate amount of funding to keep our 12 very precious beds, but it is just a small amount of what we serve. So this is our clinical nurse specialist team. This is the team that support at home. At any one time, we have actively 300 patients on caseloads that we are supporting at various stages of their journey at home. These are statistics from the end of 23, so March 23, last year's figures, which we're just putting out on our annual review. So you can see that just under 4,500 face-to-face contacts with patients at home. I Want Great Care. You'll see through the presentation I've put a couple of sort of statements. I Want Great Care is the audit tool that we use, that's part of the national audit tool around getting feedback from loved ones or patients directly, if that's appropriate. But certainly the I Want Great Care is a nationally validated tool, and so I've just taken a couple of those statements which you're all able to read, but I'm very pleased to say we consistently hold 5-star, which is the top rating for feedback, and all patients and loved ones are given that opportunity to feedback on us. It's entirely up to them whether they choose to or not, but we do 100% coverage of asking for feedback. So you would have seen around your community our St Luke's cars. That is our urgent care service. So the acronym is ELUC. It's an end of life urgent care, EOLUC. So as all health and social care providers, we have this strange language that we talk. So I even had to tune in when I joined St Luke's. I said, what on earth is an ELUC? So our end of life urgent care has been really with that's sort of the shiny star on the top of St Luke's wonderful crown. It really has been a fabulous service, and we're very pleased that we've had investment to extend it for the winter. But the healthcare assistants that go, so we have 2 healthcare assistants to every car. They have their own care runs that tends to be split into localities, and they are absolutely skilled and excel in the physical care and emotional support for patients and their loved ones that are sat at the bedside. And they will go in, we don't have it on a timer clock that, you know, they have to be in and do so many runs. They can spend the time and give really personalised care and support. And as much as we get the amazing feedback on the quality of end of life and the experience for the patient, I have to say we get overwhelmingly that's support and feedback on the how we've prepared and supported the families, so the emotional support for those sitting at the bedside. So, yeah, a lot. Say I can talk. There's a whole separate talk on end of life urgent care, and the feedback that we get on that service again is exemplary. Talked about St Luke's. You've heard in the previous presentation the St Luke's at UHP. We are really proud that we are a hospice that has a team based in the hospital. And I think for Plymouth, please don't take that lightly. It is a real challenge. We have partners elsewhere in the county, and certainly from where I've come from Baines, Bath, North East Somerset, and the hospices, both Dorothy House and Prospect Hospice at Wiltshire, do not have a team in their acute hospital. So I think sometimes we focus internally on what we can do, we want to do better, but that's having our own team in the acute hospital when there is such tensions on pressures for beds and are we delivering the right standard of care? Is there things we could be doing better? To have a team based there supporting our acute colleagues on a daily basis and advising and guiding them, again, is something that I think Plymouth should be really proud that it has. We're certainly very proud to be key partners in that service. Again, I could double the number of staff in that team. You know, we know what we want to do more and be better and support the ED project, as you saw on the slide previously. Really proud that Ali, who is the clinician leading that service, Ali was our clinical nurse specialist before she left St Luke's and went to UHP, so really strong links there. So yeah, it's a service that we can have further investment, and I know that the team there on a daily basis know that what they can always do more. We've also got our 12 precious beds at Turn Chapel. I have to do a cautionary management of expectations. It is only 12 beds. So when you have people requesting their preferred place of care and their preferred place for the end of their life to be at Turn Chapel, the priority will always be the patients who have the most complex symptoms and are needing to have the specialist medication and symptom management review of the skilled doctors and nurses on the unit. So on a regular basis, on a weekly basis, the inpatient unit are having to sadly say our beds are full and somebody's having the hospice as their preferred place of care. If the symptoms and their care is being really well managed by our colleagues that live well, just having a request to come and die in the hospice because they've had a family member, a loved one, somebody that they've seen before have a good end of life, that isn't sadly, because I have to prioritise access to those, and that it will always goes to the ones with the most complex symptom management, where our professional colleagues are saying to us, we just can't quite manage this pain, we just can't quite get on top of this nausea, this is a complex brain tumour, or it's, you know, the high risk of bleed. Those will always remain our priority, and that's the reality of resource allocation. So I just wanted to put that in, because I've heard a lot about places of preferred place of care. And whilst we will always endeavour to try and do that if we've got a vacant bed, sadly the system, as pressurised as it is at the moment, that's not always a criteria we can meet.
Patrick.
Thank you. I can just pick up on that bit about capacity. So is it St Luke's wish to develop further capacity more than the 12 beds at the moment?
No. And I say that really we've just done our strategy year, we're out to consultation. Some of you may have been asked to contribute to that, our community involvement. Our consultation for our 3-year strategy is currently out, and we hope to have that published by the 31st of March. We're very clear our focus will be expanding our community care services. That's what our community tell us they want more of. And there's a slide slide at the end of this presentation that shows you the high cost to keep an inpatient bed compared to the cost and the increased exposure we can get. We can help more people, far more people in a community setting than we can with an IPU bed.
I think that's a very important point. If nothing, I'll take an awful lot away today from this discussion, but one of the key issues is that there's a perception absolutely in the community that it's about going to St Luke's rather than being careful in the community. So we probably ought to see what we can do as a local authority to educate the wider population that actually care in the community is the preferred option. Thank you.
So the hospice coming to you. So that's the reality. I think that also so whilst we say no, we think of beds. I would much rather support my care home colleagues in supporting their end of life in their care home. So supporting and how we could do those beds a bit differently. And I know we've been in conversation with our commissioners about that. Another I Want Great Care statement, which you're able to read at your leisure. I think the other thing that we don't often think about is actually, there's two things. One, this is one of Danielle, one of our wonderful social workers. So the pastoral and emotional support for bereavement, pre-bereavement, post-bereavement, and that is something that certainly our family support services, it's a social work, there's 5 social workers part-time, full-time team leader and some support staff, and we have a wonderful team of bereavement volunteers that work within that service. So the support that we do around the social care aspect of making sure people apply for the right benefits, which has been really challenging in the last few years, making sure that perhaps their financial wishes, we talked earlier about the advanced care planning that families are communicated with. So where we have patients saying, I don't know how to have this conversation with my loved ones, very much around all our staff can do that, but assist that conversation. But our family support team, that's their USP, that they really help the communications, particularly those difficult I want my wishes conversations that patients find difficult to have at the end of life. I think the other thing is to bring that actually our children's service, so we're not registered as a provider of children's services, but of course, sadly we had a 32-year-old young man on the inpatient unit last week who has 2 preschool children. So our patches service supports the patient, the children of the patients that are on the unit. And we have got some amazing benefactors who do our Christmas campaigns, our hampers, our trips and treats for the children of our patients. So children's services, it's about the pre-bereavement, and that all sits within our social care team as well. Talked about funding. Like I say, the annual costs for delivering the service, I mean, for patient clinical services, it's in excess of 7.2 million now. And with the pay awards going on with health staff, whilst the hospice doesn't pay the Agenda for Change pay rates, we shadow it and we try and stay within 3% and hopefully try and move to 2% within that. So we will shadow it. And I have to say the doctors' pay award is terrifying us because, again, to keep our medical staff, we actually pay the national medical rate for doctors. So, yeah, that's going to be a big cost for us for whilst we all wait to see what the final settlement figure will be. And of course, 24%, we are delighted that we get 24% of statutory funding of health money. Locally, we have other colleagues in the county, hospice colleagues, who don't receive that same amount. I have to say, I'd like to think it's because we are really innovative in how we are leading the urgent care service. We can't sit outside of what the pressures of our statutory colleagues. So we are really working hand in hand with them to make sure that we are responsive and we are developing to the pressures that's within the system. So 24% of funding, like I said to you, they're £871 for a patient at home compared to 12,000 for an inpatient bed, a patient care within the inpatient unit. So it's a quite stark cost for investment.
Elsa, thank you. Can I ask the 24% NHS funding, how is that guaranteed for a 3-year period, or is it year on year and you have to keep making a case?
Yeah, it's year on year, and we do have inflationary uplift, so we do meet with obviously it's contract review meetings, and we do ask our commissioners that we do keep inflationary uplift with that. So yeah. That's it. I think the last question was, the last slide I had was if there was any other questions, but I think we've been asking as we've gone along.
You mentioned that the healthcare assistants are, going to the home and to provide sort of end-of-life care. But you then also mentioned that you're trying to increase the amount of support in the community, going into the community. But obviously, if those patients are requiring more support than purely what a healthcare assistant can support, is that going back to Live Well, or have you got practitioners within your team that are able to do that work?
Yes.
To maintain a patient, somebody at home where they want to be.
So we have the community team are led by a consultant nurse. So with advanced skills, she's non-medical prescriber. We're investing in training lots of our clinical nurse specialists to be non-medical prescribers, so that with the philosophy of one touch at the bedside, not having to hand off to a GP or to ask our consultant back at the unit to come out. So we have a nurse consultant, we have a team of clinical nurse specialists that are non-medical prescribers. We also have a medical consultant, a doctor, that for the community team, 3 days a week, but we do have, obviously we have 7-day, 24-hour cover on the inpatient unit, so we do have that medical cover should we require it.
If it's sort of end of life, last few days, but logically, at what point would you be aiming to sort of bring in this team to support, or is it reliant on the GP, or obviously if someone's been in the hospital to make the case and go, actually out, I feel that this patient would be better served by St Luke's?
So we have so for any community patient, anybody known within our catchment area, has a GP registered within our catchment area, they self-refer, and we will work with with colleagues to find out who's best to serve them. But anybody can have a referral to St Luke's. The end-of-life urgent care, which is the act for those actively dying, which is the urgent care service, we work with the criteria of the continuing healthcare criteria. And in fact, we're just doing a piece of work where we have one of our nurses sits in Derriford Hospital in the UHP complex discharge, or the discharge room, looking for those clients that are in UHP at the moment that we could take through that meet the criteria for end-of-life urgent care, and we try and get them if that's their wishes, we get them home as quickly as we can. So we're just looking, and actually had a conversation with Chris and Jane this morning. We had a meeting about how we further invest and develop that. So end-of-life urgent care, which is the cars out in the community, that's the service. It's nurse-led. We can have a nurse response within 2 hours if there's a crisis. But getting into that service there are criteria to get into there, because we would be looking at brokerage services or community services to support where that expertise isn't needed at that time, or where the other colleagues are doing that work and we're not needed. So yeah.
Any gaps that through the cracks basically, and they're not getting into your urgent care.
Yeah, like I say, the bit about the urgent care, and I keep saying we are only one part of a provision, and whilst we try and meet that, and we can be really creative at how we can hold patients, or until the point of readiness, until they do need that service. And it might be that they might just need us once a week going in to check that the domiciliary care package is working okay for them, and then supporting our domiciliary care provider, private market, in how we support them in upskilling. So we can be really creative about how we can do that to make sure that the care is right at the end for the last days and hours.
Alison.
Thank you, Chair. I should have done a follow-up on my previous question. Obviously, year on year, rolling finance is almost a bit hand to mouth, and there is a risk of cuts. Would your life be made easier if you were able to plan, say, with a 3-year funding package before change? And have you been arguing for that with the NHS?
So always, and actually, for those of you that may well know George, who was our previous director of care, who's now our chief executive, George works very hard to make sure that we get the funding, and we're lucky. We're lucky, that's not true. We work very hard. The team that support us on our income gen work really hard to make sure that as a charity, our finances are in very good shape. But we know that with, like I say, the unknowns about the doctor's pay settlement, the investment going into health colleagues, and us having to increase to make sure that we keep that differential, all of that will will hit our reserves quite significantly. So whilst in the immediate short term, we're always planning for that medium to long term position. So any certainty, because we rely so much on legacy, so much of our income will be, and again, the good people that we serve, we've been very fortunate over the last several years to have some large legacies, which whilst lovely, just gives you that one hit, but doesn't give you the trajectory of regular income. Yeah.
Chair, is that something that we could consider as a recommendation from the committee?
Sorry, Alison. As we're going along, Elliot's taking notes and stuff, so it's fine. Chris?
Just to clarify, so in terms of the NHS Devon contribution, it's a substantively funded grant. So it's not a case that St Luke's have to approach us on an annual basis to bid for funding. But what Trish is describing is the cost pressures, the ongoing conversations that we have about, as a system, how do we prioritise and support that? But there is the continuity and the sustainability in terms of that core grant payment that we make.
Sorry, can I ask, so on the back of that, Chris, so will that recognise, obviously, the inflationary pressures, both to materials and services, but labour, so obviously price inflation in wages?
So there's a standardised formula that gets set nationally in terms of the inflationary uplift, and that passes through in terms of the approach that we take with the grant. the complexity that Trish has described in terms of pay awards, recognising some of the potential increases around that, how that's passed to non-NHS organisations is kind of a national thing, but something that we continue to push around. But equally, as Trish described, we meet regularly with herself, George, and other colleagues around actually what does that investment look like, what are the ways that we can support that locally, how we make sure that we've got that equity across Devon as well. So as Trish described, there's very different services that are provided, and we're really fortunate within Plymouth that we have the ELUX service and some of the other services that have been set up, and that does mean that there is some differential, but we're working across Devon to understand what that looks like at the minute.
Thank you very much.
Thanks, Chris. Thanks, Trish. Thanks for the update. It was really appreciated. Thank you. Can we go to Sharon?
Yep. So I'm Sharon King and I'm the end of life lead for Live Well South West.
Hi, I'm Sarah Pearce. I'm Assistant Director for Adult Frailty and Specialist Services in Live Well South West.
Okay, so Live Well South West, for those of you who don't know, is a social enterprise, and we provide integrated health and social care services for people across Plymouth, South Hams and West Devon. We care for people in a variety of locations, so they could be in their own home, they can be in residential care setting, supported living accommodation, mobile homes, hotels, wherever anybody chooses for their home to be, we will look after them there. And obviously we do work with our system partners to provide that care and rely quite a lot on St Luke's for some of that specialist advice at times when, because our colleagues are generalists, they're not end of life or palliative specialists, although they do have training in that area, so they are experienced in that work. But when we want some more specialist advice, we will go across to St Luke's. And St Luke's are available to us 24 hours a day for advice. So as you can see from this list, we do have quite a few different services and professionals that possibly could be involved in the end of life care of a person. You know, from district nurses that are going in maybe to provide symptom control, to do some of those assessments, to think about advanced care planning, right the way down to, you know, dietitians or AHPs, so occupational therapy, physiotherapy. It's about making the best of somebody's last months or the last weeks or the last days of life. So between January 2023 and December 2023, we cared for 1,335 people who were entering the last months, weeks and days of their lives. 575 of those people were supported to die in their own home. 596 died in care homes where patients, families and colleagues in care homes were supported by Live Well professionals to care for those people. So 63 of the people that were actually on the caseload of our services died in the local hospice. Reason behind that is if we've got somebody at home and their symptoms maybe are difficult to control, and it's like Trish said, that they get priority of a hospice bed. So sometimes we have to contact our St Luke's colleagues to say we're really struggling with that. And we have got the knowledge of the St Luke's advanced practitioners who can come into somebody's home and they can adjust medication and help us with the symptoms. But if we're not managing, then sometimes those people do go into the local hospice, and that's sometimes where they do die. And 75 of the people that were actually on our caseload did die in the acute hospital. Again, that can be varying reasons. It could be that despite what somebody's TEP form says, and I agree that the TEP form isn't the be-all and end-all for people, that sometimes their symptoms are treatable. So perhaps somebody is seen, because when we talk about end of life, we do talk about the last 12 months of life. So it could be that somebody's maybe got a chest infection, or they've got a urine infection, or they've had a fall, and we do need to get that person into hospital, that maybe home's not the best place for them at the moment, and their condition is treatable. So they could have gone into hospital for those reasons. And for 36 of those people that were on our caseload, I don't know if where they died, because it wasn't documented. I couldn't find that anywhere. And sometimes that's because maybe they've been out of area. So the way I've thought about when I've done this is looking at the ambitions document and how it is that Live Well South West are trying to meet those ambitions, and what it is we're doing about that. So every person that we come into contact with, we do treat them as individual, and we do have individual care plans for those people. And when we're talking about individual care plans, it is a care plan that includes the individual and their families. As long as the individual's happy for families or other people to be involved in, for us to share information, we include them in that. And it is a dynamic process. So just because on the first visit we go in and we'll start planning somebody's care, it doesn't mean to say that's not going to change with the patient's condition or with their wishes further down the road. So we've also, I think Shane said this at the beginning, we've tried hard over the last sort of 18 months to train some of our more experienced nurses and allied healthcare professionals to have those advanced, difficult conversations with people about long-term plans and their long-term wishes and the treatment escalation plan. And we've now got 21 experienced community professionals who can actually have those conversations and write the treatment escalation plan, get the word out. Our expectation is that the patient is included in those conversations, and so are their families. To the point, even with the electronic tech, the expectations are that that will be printed out and it will be sent to or given personally to the patient and their family, so that they know the decisions that are being made about them. But we would expect that those decisions have been made with them and that that's been shared with them. So along with the TEP form, advanced care plans are written and reviewed and amended with the person, depending on their change in need. And again, that reflects change in need. We do have chaplaincy support, because when we're talking about Live Well, we've also got some community hospitals. Chaplaincy support is offered to the inpatient units and the patients within those units. In the community, that chaplaincy support extends to advice to our staff. So where a patient in the community maybe is needing some of that chaplaincy support, we would either go to our own chaplaincy, or we'd go to St Luke's for advice and get some signposted from them as to who's the best person for us to go to. We work closely with partner organisations, and obviously some of that has been around developing the electronic TEP. Each person gets fair access to care. So we cover a wide and diverse area of populations across rural and inner city deprived areas. Like I said, we'll visit patients regardless of where they live in the community and provide care for them. Everybody receives an individual care plan. People are listened to, and we do respect people's choices. And we feel at the end of life that's really important for people to have those choices. This is like everybody has said here today, this is the last chance to get it right. So let's try as much as we can to make those choices happen. But we are honest. So some of some of the choices that people make, it's not always possible. It's not always when we're talking about preferred place of care, if somebody wants to die at home, it's being honest with the person and actually saying this is not always possible. We can't always provide 24-hour-a-day care in somebody's own home. So it's being realistic about that, but being honest from the first. So from the off, we are being honest with those people about what choices are available and how much we can meet those choices. I mean, we will have conversations with people about what's available, and we can help arrange care homes if people's choice is care homes.
Can I just, Alison just wants to come in with a question, if that's all right. Thank
Sorry,
you.
I mean,
Hi, Alison.
it's really interesting hearing you talk about care packages and how they're put together and so on. And they're very physical health based. I haven't had anybody talk about the mental health issues around those patients and the partners you might need to work with there. And I'm assuming that that's not a problem, but part of the mental health and the stress patients have and their families have are around the arrangements post end of life. Do you talk to people about whether or not they've got a will, whether or not, and we come back to the power of attorney thing, is that part of the package? And because that will affect people's mental health, and there's sort of certainty that things are organised, if you like.
Yeah, yes. So that's exactly what we do. So when I'm talking about individualised packages of care, I'm talking about a holistic. So that takes into consideration people's emotional, psychological and spiritual needs as well. And we also then think about people's capacity. So when we're thinking about some of those patients that maybe are newly diagnosed with dementia, say, we're then thinking, okay, this is the time we need to be thinking about advanced care planning. We need to be thinking about lasting power of attorney for health and welfare and for finances, and thinking about the needs of the family, which is what else we also take into consideration when we're thinking about individualised care. So yes, so district nurses will go in and regularly review somebody's symptom control. We will go in and we'll adjust medications. So we do have some district nurse specialist practitioners that are non-medical prescribers. So they're able also to go in and adjust medication to suit the person and to make sure that their symptoms are controlled. And we will go in and we'll give them stat doses of medication, or we'll think about, okay, does a syringe driver need to be set up to better control the symptoms that somebody's got over a longer period of time, and to keep the symptoms level and to the symptom control level. So, yeah. And we also, like I said, there's many people who are involved in the care of people at end of life. So we will refer to other disciplines. So if we've gone in and I don't know, somebody needs a razor seat maybe for their toilet, that's something that we can do, or we can refer to occupational therapists to come in for other adaptations that maybe need doing to somebody's house, or get physios in, or even podiatrists who can come in and help with somebody's foot care. So there's lots of things we could do. If people are struggling to swallow with some diseases, that will happen. Then we've got our speech and language therapists that we can also refer to and get them to come in and do assessments for us. So our when we're talking about maximising comfort and well-being, I think we sort of hit on a little bit of this earlier on about planning for the future. So we start planning before somebody's died about the bereavement care that families will need, but also discussing with people, because some people, when we talk about grief and bereavement, some people actually start feeling that on diagnosis. It's the loss of the life that they've been leading. So we already start thinking about, okay, what are the bereavement needs for this person and helping them through that, and then preparing family as well for the post-death time and the bereavement and grief that they may feel afterwards. So some of that for us, our community nurses will go in and they will verify somebody's death, and that makes it really quite timely. So many years ago, it's something that doctors used to do, and it could take quite a long time with the busyness of the doctors to get in there. But now we can usually get in certainly within a couple of hours, we can get in and we can verify that death. And it's for the family, it's often with a nurse that they've actually known, so somebody they've been seeing for some weeks. So that's quite nice for them as well, and it's a bit of closure for them. And we can talk people through that. So when we're verifying a death, we don't automatically go in and assume it's something we're going to be doing ourselves. We also invite the family, is this something that you want to be involved in? And the same as our care after death, you may know that as last offices. We also invite the family to take part in that if it's something that they want to do. So care being coordinated. Some of us are on the same electronic systems, so we're able to see each other's clinical records on the systems. The advent of electronic TEP helps as well for us to coordinate care. Early recognition of the dying patient would also help with that, and we realise that not everybody's, we're not great all the time at recognising maybe the last 12 months of somebody's life. The people that we visit, we also give contact numbers to. I think this is where we have some real difficulty in end-of-life care in the community. It's the coordination of that care. Because at the minute, if a relative or a person who is dying needs somebody, there are so many people that they can actually contact. So they can contact our district nurses, they can contact St Luke's, they can contact 999, they can contact their GP, they can contact 111. Who are you going to go to first? If we actually had a dedicated coordination system with one phone number, how easy would that make life for the people who we're caring for? So Liverpool do provide training for our staff and for other people in our community. Some of that training is what we provide. Some of that training we provide in conjunction with St Luke's, or we do it together as well with UHP. So depending what the training is. And we've been doing that in several ways. So we do it also across the community. At the minute, I'm working with St Luke's to provide some podcasts for our GPs. So there's lots of things that we're involved in around education, not just for our own staff, but across our system. So communities being prepared to help. So some of that is around our compassionate city, but some of it is also about normalising dying, so making dying a normal part of our lives. It's as somebody said earlier on, it's something that it's going to happen to all of us. So let's try and normalise that. We all take part individually in Dying Matters Week, which this year is from the 6th to the 12th of May, and do it individual things. Well, why can't we all come together as a compassionate city and do something together? Why not? We could do it bigger and better, maybe. So gaps and areas for development. Strengthen our current home care service, which was set up in COVID and is something we're working on. Sarah will talk to you in a minute a little bit more about the project that's going on with that. We're also working on coordinating or having a patient information leaflet for all of our services. At the minute, each of our organisation has some sort of patient information, but there's just so much of it, isn't it? I mean, if somebody from Livewell's going in, we take our information. Somebody from St Luke's is going in, they take their information. Maybe the person's been into UHP and they've been given information from there. So it's coordinating that. So we've got the same information in the same place, and we're only given it once. I'm working on a care coordination hub. Sarah, do you want to talk about the care home?
Yeah, so pre-COVID, we didn't have a care home service as such. So people living in the community, whether they live in their own homes or in care homes, would receive community services like district nursing, community therapy, adult social care, and specialist nurses from across the patch. And in COVID, one of the things that happened, you know, it's one of the good things that happened in COVID, was it helped us to think about trying to bring together a care home service. So it was around reducing footfall. So, you know, we'd often have nurses literally kind of waving to each other as they go out of the same care home because patients were attached to different practices. So different nurses were going into the same places. You know, we were able to do things like using some technology like iPads so that if a nurse was in there, they could actually look at a wound with a podiatrist so that the podiatrist didn't have to come in. And that was around protecting care home residents and care homes as much as being smart about using resources. So one of the pieces of work that we've started to do internally in Live Well is to try and build a case for what that might look like going forward. So having a dedicated care home service team who provide district nursing, community therapy and adult social care, probably some pharmacy, probably some podiatry, and then links to all of the specialist services. So that programme of work is underway and it's reporting into our Healthy Lives Partnership, so working with my colleagues at UHP and in the ICB, and we've had our meeting today actually just to share the first iteration of what that might look like. So we'll be working that up. And then I guess the other thing that Sharon mentioned around the care coordination hub and spoke. So we all recognise, and I think all of our system recognise, that actually we could do better if we had care coordination. So there's currently a Devon-wide hub pilot, which runs from 8 a.m. till 8 p.m. And people who are in the community and at risk of admission and have had SWAST come to see them, the SWAST crews can ring into the CareCo hub and speak to a clinician and a specialist paramedic, and they can try and work out what else can we do together to try and keep this person in the community. And then that Devon-wide hub has some local spokes. So we're in the Western Patch. So our Western spoke is made up of our acute GP service that are based up at UHP and our crisis response teams that are based in the community, talking to each other about coming up with something that we can develop together to help that person stay at home. I think what we'd really love to do is, as that pilot develops and becomes more business as usual, which we're hopeful it will, that we can also include end-of-life specialist advice in that. So I think they're the things that, from a Live Well perspective, we'd really love to see develop as part of a wider system approach to help people at end of life.
Has anybody got any questions? Alison?
Yes, sorry. Sharon, you touched on Dying Matters and the week that happens, but you suggested you left it hanging, sort of begging us almost to do something.
Yeah.
What would you like us to do? You know, do you want a Dying Matters day that the council and everybody's...
Yeah, why can't we? Why can't we do exactly that and maybe promote it, have it out there in the public domain a bit more? On the council website, let's do something together. Can't we do something in Drake Circus as a system? Yeah. I mean, in the past, we've been to, I've stood in the foyer at Tesco with all the Dying Matters stuff, promoting things, because what Dying Matters is about talking about dying. So like you said earlier on about lasting power of attorney, we could be discussing that, advanced care planning, because advanced care planning shouldn't be left until you're dying. We should do them now. That's, you know, it should be done now when you're thinking about it. So having those conversations early. So yeah, I've been to Tesco's, I've been to Co-op, I've been out to Kingsbridge. We've done things in public, but I think if we did it as a collective, we could do it bigger and better.
Thank you. I think Councillor Aspinall wanted to come in. I was waving my pencil well then. We've got Ruth online there as well, so I think we've got our first Ageing Well workshop or planning sessions next week. So Sharon, I'm very happy to take that to that with. I know it's not specifically on that, but I think
we as a council, you're right, we need to be working with you to make something of that 6th to the 13th. Ruth, would you agree with that? Yes.
Yes, certainly. I'll take that as an action. Thank you.
Thank you.
Patrick?
I'm not sure it's part of this subject, but it's a totally different issue, and that's euthanasia. As a society, I think at some stage we ought to be having a debate. So we're having a debate about end of life, but we ought to have a debate about euthanasia as a principle, when other countries, not dissimilar to us, like Canada, Belgium, the Netherlands, New Zealand, Spain, allow a certain amount of that euthanasia to happen, particularly around tragic illnesses that people have to endure for months and months and months. MND's high profile at the moment, a dreadful illness. So I don't know where we are as a society in the UK about the debate around euthanasia, but I wouldn't mind possibly before we close this, and I know we're going to adjourn today, but before we close the whole topic, I wouldn't mind just a discussion in this forum as is there anything we should be doing as advocates for the constituents we represent around the debate about whether euthanasia is something that Britain should allow in the future?
Will?
Well, just also Tricia and Sharon say I don't know one sort of between you, but what do you think are the main differences in the expectations between the services available and what patients and their families, the services you provide, end of life, and what people expect? What do you think are the main differences that cause you a challenge? You mentioned just now about the hospice, you know, that actually you're there to do the palliative care, which palliative means to not shield, is it? Mask, isn't it? The meaning of palliative, the Latin means to, but you know, look at people's symptoms, isn't it? And so, what do you think are the main differences that cause and the challenges to overcome and make the end of life? People think more about the end of life as you're advocating.
So the hospice movement, as you'd expect, we've got long legacy around trying to support our communities to have those difficult conversations. So, and I think it certainly links with the difficult conversation with the assisted dying. And I can tell you the Hospice UK, who's one of our governing campaigning bodies, have deliberately taken a neutral stance. It was a very big topic for our national conference in November, and we had colleagues from New Zealand come across and speak at that. In fact, we have a colleague joining, Rowcroft, from New Zealand, who has been a hospice nurse who has worked in a hospice that had the assisted dying facility. And we know that that was so badly implemented across New Zealand that there's a lot of learning that we should do and bring there. So for the assisted dying conversation, I was part of a conversation in 2014 when it had its last reading through government, and we had a barrister who was advising government come and talk to us, and I've spoken to colleagues at St Luke's to say we'd want that level of debate, and we would be very happy to host that in a much larger facility so that we could bring all partner agencies in to have that. So Hospice UK are taking a neutral stance, and they have said that they are not expressing a wish either way. They've advised hospices nationally to take a neutral stance. That is phenomenally different to where we were in 2014, where it was an overwhelming no, because that facility and the expertise to assist somebody to end their life, everybody will be looking at palliative care clinicians to do that. And I know that is very, very unpalliative. Our colleagues, my colleagues will find that really challenging and really difficult. So it's a very hot and very real debate. Isle of Man also, Scotland are currently having a reading that's expected to go through in March. So it's already here with us. And again, Hospice UK was held in Scotland in November, and colleagues from St Margaret's, which is one of the largest hospices in Scotland, spoke very passionately about they would not wish to be put into that position. They were very anti having to offer that facility, because it goes against the whole principles about palliative supporting somebody to remain pain-free with dignity and quality of end of life. So it goes against everything that a palliative care consultants, either nursing or medically, believe that is their DNA and their USP to do. So as a community, we're going to have those debates. They're here in real and live. I think the key bit for us is around how we can support everybody to have a dignified, personalised end of life and death that brings quality and dignity. And sadly, because of the pressures that the health systems and social care systems have been under coming out of COVID, we know that we're caught with that legacy, that it's been very challenging to deliver that. But you can see by the fact that we're all here in front of you today, having that discussion and being willing and open to be scrutinised, that we really do want to make a difference. That's why we're here.
Okay.
I can just thank on behalf of members, and I'm sure you do, but we appreciate you giving your time up today to be here and aid in this debate. And it's difficult for members, because you're living with it on a day-to-day basis and applying all your professionalism to dealing with our constituents in care settings in the hospital. We're not. We're only dealing with it in personal circumstances, so it is tough for all of us. But I welcome very much all that you've said, and thank you.
Thank you. It's really been interesting today, and I'd just like to thank you all, because obviously you can see that there's some positives that's coming out of all of this now. So I really do appreciate that, and I welcome what you are doing. What we're going to do now is we're going to adjourn this meeting, because we have got another part of this, but I think we need to give it the attention that it actually does need. So what we'll do is we'll adjourn now, and the second part of this meeting we'll probably put together in maybe a couple of weeks. Elliot, I mean, we'll have to find a slot. I mean, obviously we didn't expect this, but I think it's been really interesting today, and thank you all for coming. I really do appreciate it. Members, thank you all for coming today. Not that there's many left of you now.